So everything is fine. Can I go ahead?
Yes, sir.
Yeah. So as we discussed all these things, we discussed basic ECG, what is the conduction system and all, and what is this SA node, everything, and what are the P waves, QRS, T waves, and all these things. And also we discussed about how to calculate rate, rhythm, and also we discussed about waves and intervals. Right, all these things, just only brief discussion we gave. What are the abnormalities of different waves we discussed? Prolonged P wave, elongated P wave, wide QRS, narrow QRS, and again we discussed about short PR interval and long PR interval and short PR segment also we discussed, and ST elevation, all these things we discussed. Right, in the leads also we discussed already, lateral leads, anterior leads, anterolateral leads, all these things we discussed. Right, in introduction to arrhythmias we discussed about all these things, which is supraventricular tachyarrhythmia and ventricular tachyarrhythmia. Only thing you have to remember is any impulse which is going through the conduction system, they will conduct very fast and depolarize ventricles very fast, so your QRS complex will be narrow. But any impulse which travels through the ventricular muscle, their depolarization is very slow, so that's why they have wide QRS. So supraventricular tachyarrhythmias are narrow, ventricular tachyarrhythmias are wide. Right, till then we are clear. All these things we discussed. What is the tachyarrhythmias and also narrow and wide. This in the previous class we discussed all these things. Right, so this PSVT, all these things we discussed, AVNRT, all these things. For the people who missed the previous class, just a gist of summary I am giving you right now. After this we'll go for the other things. So what we discussed in the previous classes, we discussed about all the narrow complex tachyarrhythmias. So I think everyone understood well. Any doubts also you can ask now. So for the people who missed the class, I am giving a small gist. So simple the thing. Right. So anywhere you are seeing, first thing what you have to see is whether tachyarrhythmia is there or not. How are you seeing tachyarrhythmia is there or not? You are calculating the number of boxes between two arteries. If it is more than 100 and all, there is tachyarrhythmia is there. The next thing you are going to see is whether it is narrow complex or wide complex, right? So narrow complex, we already know, we discussed, they are supraventricular tachyarrhythmias. Wide complex, they are ventricular tachyarrhythmias, right? In the supraventricular tachyarrhythmias, immediately we discussed only one thing, whether it is a regular, right? And again that if P waves present or not, we are seeing, right? If it's a regular and P waves are present, that is your sinus tachycardia, and regular P waves absent, that is your usually what is called as supraventricular tachyarrhythmias, that is your AVNRT and atrioventricular re-entry tachyarrhythmia. These things we discussed, right? Similarly, if SVTs, if it is irregular and P wave absent, that is your atrial fibrillation, and similarly if it is irregular and P waves are present, that is your multifocal atrial tachyarrhythmia. This much we discussed, right? So basic small classification we made. If it is regular, P waves present, sinus. If regular, P waves absent, that is your AVNRT or AVRT. If irregular, P waves present, it is multifocal atrial tachycardia. If irregular, P waves absent, it is atrial fibrillation. I think no one will have doubt in this thing. We discussed extensively with examples and all in the previous class, right? Then one more thing is right, 1 minute. Right, so you saw tachyarrhythmia, then you saw it's a narrow complex, then you discussed it is SVT. In that you saw irregular, mostly it is AF, atrial fibrillation. If it is a regular, then you have issue is there, regular and P waves absent, then you have usually that supraventricular tachyarrhythmias, that can be either AVNRT or AVRT. This is only we discussed, right? In the AVNRT again you have either slow fast type or fast to slow type, right? And AVRT you have orthodromic, antidromic pathway, right? This is only we discussed. Just I am giving. I am not going in detail. Just this I am giving, right? In this, what you have to remember is this fast to slow type is less common. No need to remember. Leave that thing, right? Similarly, this antidromic appears like a VT, so we can easily differentiate. That is also no problem. We can differentiate the thing, right? Now the thing is this low fast type and this orthodromic pathway. This is only doubt is there. Just see for the P waves, right? If the P waves in the V1, V2, if it is just near to QRS complex, that is your AVNRT. If it is far from the QRS complex, that is your orthodromic AVRT, right? I think everything we discussed this thing in detail. You just go to the previous lecture, it will be very easy. I just gave a flowchart of this thing. right? So narrow complex tachycardia, regular, no PVS are there, either AVNRT or AVRT. In the AVNRT, you have to differentiate slow fast AVNRT. In the AVRT, you have to differentiate orthodromic AVRT. Just see for the P waves, the V1, V2, and also lead to. In the P waves, if they're nearer to the QRS complex, that is slow fast AVNRT. If they're far from the QRS complex, that is your orthodromic AVRT. Right? Clear? Right. After going to the discussion, we'll go to the wide complex tachyarrhythmia. This is what we discussed. Right. 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 So again, same, the wide complex tachyarrhythmia, let me draw a simple flow chart, simple diagram for it. It's very easy for you. For example, if you are seeing a wide complex tachyarrhythmia, wide complex tachyarrhythmia. Same here also you have to go whether it is a regular or irregular. Okay. Then you have to say one more point, whether it is a P waves are present or P waves are absent. Same irregular also P waves are present or P waves are absent. Simple, very simple flowchart, the same flowchart, the thing we are doing everywhere. Okay. Right. If it is a wide complex tachyarrhythmia, regular and P waves are present, then you have to see here, this is simple. It's just only sinus tachycardia with bundle branch block. Already patient has some LBBB or RBBB. Apart from that, he has some sinus tachycardia. So they have wide complex tachycardia only. Regularly they are there. Then they have POS are present. So it's a wide sinus tachy bundle branch block. And this one, if it's a wide complex, regular and POS are absent, there are 3 DDs are important. That is, first is your ventricular tachycardia, very very important. Second, same your AVNRT, that's AVNRT with the bundle branch block. That is very very important. Right? And third, AVRT, antidromic pathway. All these things we discussed in the previous class. Antidromic pathway. Right? Clear? So patient having wide complex tachyarrhythmia, but regular rhythm, but PVS are absent. That means it's a ventricular tachycardia. Or atrioventricular nodal reentrant tachycardia only, but there's a bundle branch block already is there. That's called as AVNRT with AVB. Right? Or AVRT, antidromic pathway. I think it's clear. Right? And then it's a wide complex, irregular is there, PVS are present or PVS absent. If PVS absent, simple, only thing AF with bundle branch block. Its present is a multifocal atrial tachycardia with bundle branch block. Okay, so is it okay? Is it clear? Same, this flowchart already we discussed in the previous class. So for the narrow complex we discussed, now we are applying for the wide complex. So wide complex means the complex is originated, the depolarizing current is originating from the ventricle and it's passing through the ventricle. Because ventricular muscle is not specialized conducting tissue, it goes slowly, it depolarizes slowly, so your QRS will be wide. Right? So there are some things how to differentiate different VT wide complex tachyarrhythmias. You see 2 things, one is your regularity and other is your P wave. If it is regular, P waves are present, he is a sinus tachycardia only, but before he has a bundle branch block. Okay. If regular, P waves absent, 3 DDs are very very important. One is your ventricular tachyarrhythmia and other is AVNRT with the bundle branch block or AVRT in an antidromic pathway. Okay. Very very important. This we discussed in the previous class. You can just go through the previous class. Similarly, irregular P waves are present, that means MAT with bundle branch block. Irregular P waves absent, AF with bundle branch block. Simple flowchart. Right? Okay. Understood? I can go ahead. Right. So this is the important question they're asking. Why I'm discussing extensively this ECG is this ECG is not like just like a X-ray or like this. They won't put a spotter like this. ECG is very important for the OSCE. Even the OSCE out of some 25-30 questions, they're asking some 3 to 4 questions of ECG only. They're just putting a simple ECG or they're just giving a clinical scenario. They're just asking you to identify how to differentiate it from other thing and what is the management they're asking. So this is what we are discussing in the today's class only. Right? All the management also will discuss. So that is why I'm extensively covering ECG. In the just 1 minute time only, you have to identify the ECG. Right? That's why I'm giving all these important flowcharts also, easy flowchart. Right? So whenever you see the wide complex tachyarrhythmias, immediately you saw the wide complex tachyarrhythmia, you saw the ECG, QRS complex are wide, you identify it's a wide complex tachyarrhythmia. Now what are the DDs are there? We already discussed. One is your ventricular tachyarrhythmia. That is the first thing you have to come into your mind. Second thing is SVT with aberrant conduction. What is SVT with aberrant conduction? The patient has a supraventricular tachycardia, but he has an aberrant conduction, means some bundle branch block is there. So because bundle branch block is there, patient is having wide complex, but because supraventricular tachycardia, he has a, it is coming SVT with aberrance. Example is same only, that is your AV and RT with bundle branch block. That is called as SVT with aberrance. Is it understand? SVT with aberrance. SVT means supraventricular tachycardia. Usually it's a narrow, but aberrance patient already have a bundle branch block. So that's why he is having wide complex. So this also can be a wide complex tachycardia, right? And the third thing is pacemaker in tachycardia. I will discuss about this thing. And fourth is any metabolic hyperkalemia, very important. Wide QRS complex can be seen in hyperkalemia. And fifth is last is TCA poison, tricyclic antidepressant poisoning. Any ECG showing wide complex tachyarrhythmia, you have to understand these 5 things are very important. One is ventricular tachyarrhythmia, other is SVT with aberrance, other is pacemaker tachycardia, and other is your hyperkalemia, other is your TCA poisoning. Right? In this thing, one important thing is you can you can rule out this TCA poisoning by asking history and all. Just I want one important point I want to mention. If there is a TCA poisoning, like tricyclic antidepressant, immediately not anything, the patient usually have wide QRS complex tachycardia. Usually bundle branch block will be there, and usually they will be in high attack of seizures are there. Only thing you have to do is you have to alkalinize the urine. You have to alkalinize the urine. So drug you can only give is soda bicarbonate. Very important. This is also one of the viva question they will ask you. Okay. And metabolic derangements you will see from the your potassium level you will see. Just let us come to the pacemaker mediated tachycardia. I'll just show you in the next slide how it is. Right. So before going to see this ECG, let us see this one. This is a normal heart. Okay. These are ventricles. This is AV node. This is your atria. Okay. Usually SA node is coming, then going to AV node, then going to your bundle, then Purkinje fibers and depolarizing ventricle. This is the normal thing. So when normal thing is happening, whenever SA node is there, you have P wave. Okay, as it passing through the AV node, you have PR interval. Then as it passing through the ventricles and all, because it's going to conduction system, you have narrow QRS complex, then ventricular repulsion T wave. Accepted, right? But now what will happen in the pacing, we'll see. What will happen in the pacing, we'll see. For example, this is the pacing, right? This is your ventricle again. This is your AV node. Okay, this is the atria. Okay. Now pacing means you are putting some pacemaker. The pacemaker usually will put in the right ventricle. Very important. Right? So usually put in the right ventricle. So now what is happening is here SA node is not the pacemaker. Now even this spacer is the pacemaker. Usually put this spacer in the right ventricle. So what is going to happen now? This is generating impulse and it is transmitting impulses to the entire ventricle. Right? So because SA node is not contracting, you will see P wave, no P wave, definitely there is no P wave because SA node is not contracting, atria is not contracting, there is no P wave. Right? And it is not passing through the PR interval, it is not passing through AV node, so therefore there is no PR interval also in ECG. Okay? Now, pacemaker, from the pacer it is coming and it's traveling through the ventricular muscle. Because it's traveling through ventricular muscle, you will have wide QRS complex. Okay, so this is called as pacemaker rhythm. So they will have no P wave, no PR interval, they will have wide QRS complex because you kept the pacer in the right ventricle. From the pacer, impulses are generated and it is depolarized in the ventricle. Right? So now there is no sinus node is contracting, no atria is contracting, no P wave. It is not traveling through AV node, so no PR interval. Only thing you can see is it is only ventricles are contracting and the impulse is traveling through the ventricular muscle, so you will have wide QRS. Right? So how will you identify this thing? Just let us see this ECG, you will understand now. Right. So see this ECG right now. Right. So this is the 1 minute. Right. So this is wide QRS complex. You can see. Okay. QRS complex and T. QRS complex and T. Here also QRS complex and T. QRS complex and T. And this is QRS and this is T. Right. You are seeing wide QRS complex. Are you able to see the P wave? There is no P wave. Why? Because there is no SA node is contracting. But what you can see is this deflection. You can see. What is this? This is the deflection. This vertical mark you are seeing. Are you able to appreciate this vertical mark? Okay, that vertical mark is nothing but your pacer rhythm. Your pacemaker. Please mute the audio. Someone is speaking. Please mute. Okay, right. Here pacemaker is contracting. That pacemaker contraction you will see as a vertical line. Right, that is a vertical line. This is a vertical line. Okay, immediately after patient ventricle starting contraction, there is no conduction through the AV node, so there is no delay, so therefore there is no PR interval. So there is no PR interval, right? Immediately after this pacer, immediately ventricle is starting, so therefore immediately after pacer you will get a QRS complex, and it is going through the ventricular muscle, so therefore wide QRS complex, right? You can understand this thing. I think it's easy only, right? So there is a wide QRS complex, no P wave, no PR interval, there is only just a pacer rhythm, just a vertical strip immediately followed by your ventricular contraction, which is a wide QRS complex. Then you can add with the pacer rhythm.
Okay, sir. Sir, can we tell which pacer through ECG?
Which pacer through ECG? Right ventricular pacing will appear as a LVB, left ventricular pacing will appear as RVB.
Okay, sir.
Right? So how to identify LVB, RVB, I will discuss in the last slide of this PPT. Right? Right. So this is the thing. So whenever you see the wide complex tachyarrhythmia, you have to remember three things. One is hyperkalemia ruled out, right? Another thing is you ruled out your TCA poisoning. You ruled out the thing. The three things examiners are going to ask only these three things. Very important. Ventricular tachycardia, SVT with aberrance, and pacemaker mediated tachycardia. In pacemaker, how are you identifying? You are identifying only just simple. In pacemaker tachycardia, you will just see the vertical slide, then followed by your wide QRS complex, then T wave, right? Again vertical slide, then followed by wide QRS complex and T wave. That's it. There is no P, there is no PR interval because it is an SA node is suppressed, it is not going through AV node, right? Then how to differentiate ventricular tachycardia and SVT with aberrance? This is the hallmark standard examiner questions, right? This is the one. How to differentiate between these two, VT and SVT with aberrance, right? Any patient who is having some supraventricular tachycardia, that is narrow complex tachycardia, but he inherently has a bundle branch block, they appear as a wide complex tachycardia. Or any patient who is having ventricular tachycardia, he also appears wide complex tachycardia. Now, how to differentiate between these two things? Because the management is very different in these two things, you have to differentiate definitely. So how to differentiate is the question. Even when I go for SR-ship, my SR-ship question also this one. So every time they'll ask this question, how to differentiate VT and SVT with aberrance. Pacemaker will identify just with the vertical strap and wide QRS complex. In hyperkalemia and TCA, based on history and based on all these things, will identify. But these two things identifying is very difficult. So for that, we are going to one beautiful slide. Right. Just see this slide. Each and every point is important. That's why I didn't put in two slides. I just kept in single slide. So just follow with me. What are these points? We'll see. So how do you confirm it is a VT? Once you see wide complex tachyarrhythmia, you ruled out hyperkalemia, you ruled out your TCA poisoning, you ruled out your pacemaker rhythm. Now two things are there, either VT or SVT with aberrance. So how to confirm as a VT? How to confirm as a VT? Right? The first thing, it should have very broad complex as we discussed, wide QRS complex. Okay, QRS complex of greater than 3 small boxes. Yes, we confirm that thing. First thing. The second thing is there is absence of typical RBB and LBB morphology. What is that means? In RBB you will see RSR pattern, right? In LBB you will have some double pattern, but that type of pattern won't be there in the case of VT, right? If that pattern is there, you can say okay, maybe right bundle branch block or maybe left bundle branch block. The typical RBB, typical LBB pattern should not be there in the ECG. Right? And one important point, very important, extreme axis deviation. What is the extreme axis deviation? That's called northwest axis. So what is the thing? Because of ventricular tachycardia and all, the heart will tilt in a different axis. So usually it is in the left axis, but it will go into the northwest axis. So how will you identify this northwest axis in ECG? No complication, just only identify this thing. You see only AVR, right? If AVR is positive, that is considered as a northwest axis. Simple. Don't unnecessarily complicate your life. So usually heart lies in the left axis. In ventricular tachycardia, heart comes into the northwest axis. How to identify that heart is in the northwest axis? Just see the AVR lead. Every time AVR lead is negative. In a normal ECG, whenever you see AVR lead is negative. But if AVR lead is positive, it indicates northwest axis deviation. That is typical, specific for the ventricular tachycardia, specific. Right? Then you see the capture beats, very important. Let us see what is capture beats. Right. So what is capture beats here? Let us see this thing. See, normally in ventricular tachycardia, what is going to happen? SA node is suppressed, AV node is suppressed, only ventricle is contracting, because of that you are having wide complex tachycardia. But sometimes maybe sinus node may depolarize, so that impulse may reach through the conduction system and come to ventricle. That is called as capture bit. That bit is captured. So because it is passing through conduction system, you will have narrow QRS. Clear? In ventricular tachycardia, usually SA node is suppressed, AV node is suppressed, only ventricle is contracting, so that ventricular depollution coming to the ventricular muscle, so you'll have wide QRS usually. But sometimes one or two beats may come from the SA node conduction system come to ventricles, so it is traveling through conduction system, you will have a narrow QRS. That is called as capture beat. So you are capturing that narrow QRS. This is what I wrote here. Occur when the sinoatrial node transiently captures the ventricles. So in midst of AV dissociation, it produces a QRS with a narrow normal duration, narrow QRS. You will see one or two narrow QRS. That is called as capture beat. And next is fusion beat. What is fusion beat? So this sometimes is capture beat fused with the normal ventricular fusion wide complex beat, producing a fusion beat. That's what I wrote here. Occur when a sinus node and a ventricular beat coincide to produce a hybrid complex of intermediate morphology. I will show everything in the image. Okay. So all these points are important. Please, you mug up this slide. Right? That's very important thing. It's a very broad complex. No LBB, RBB morphology. Extreme axis deviation. There should be capture bit. At least one or two capture bits. Maybe you can find out. And this capture bit and normal bit they'll fuse and together form fusion bit also. Right? And one more important specific finding, very important finding, that is called as positive or negative concordance. So don't think it is not our level, it's our cardiology level. No, it is completely physician level. This is the question they're going to ask you, and if you are going to say this only, they will pass you also. Right? So what is positive or negative concordance? If we see from V1 to V6, from the V1 to V6, all the leads should be either positive or negative. That's it. Okay? From the V1 to V6, this QRS complex should be either positive or either negative. It should not be like V1, V2 negative, V5, V6 positive. It should not be like that. V1, V2, V3, V4, V5, V6. Everyone have positive QRS complex, positive concordance. Or V1, V2, V3, V4, V6. Everyone has QRS of negative complex, that is negative concordance. Right? That is again highly specific for the VT. Right? Clear? And next comes your Josephson sign. What is Josephson sign? There is nothing but notching near the nadir of the S wave. let me draw this. Okay. For example, this is your wide QRS complex, right? Right? Exactly at the S wave, they'll have some notching will be there. Some notching will be there in the S wave. This one. That is called as Josephson sign. Right? And other is Brugada sign. What is Brugada sign? From the beginning of the QRS complex to this S, to this Josephson sign, it should be less than, it should be greater than 100 milliseconds. That's it. These two are just only theoretical purpose. I don't want you to learn these two things, but just remember this thing. Some examiners are interested was what is Josephson sign. At the nadir of the S wave, there is a small deflection that is called Josephson sign. From the beginning of QRS complex to this Josephson sign, it should be greater than 100 milliseconds. That is called as Brugada sign. Right? And again, one more specific finding is there. This is left rabbit ear. What is left rabbit ear? If you see this RBB pattern, if you see RBB, okay, you will have RSR pattern, wide QRS complex. Okay. So in the wide QRS complex, because RSR pattern, if you see left, this is your left limb, this is your right limb. Like left is small, right is big. Like a rabbit ear. Rabbit left is small, right is big. But in the case of VT, what is going to happen in VT? Left will be big and right will be small. That is called as left rabbit ear sign. Right? How to differentiate RBBB from VT? In a VT, the left limb will be small. This left limb is small. Okay? But in the case of VT, the left limb is very high, very tall. Everything I will show you ECG. Right? All these points, please do remember. Please don't forget. How do you confirm it as a VT? First thing, you have wide QRS complex with no LBBB, with no RBBB. Right? And second thing is extreme northwest axis that you can see as AVR positivity. Very important thing. Right? And third comes your positive concordance or negative concordance. That means from V1 to V6, QRS complex should be either positive or either negative. It should not be mixed. Right? Then comes a capture bit. Somewhere you will get some narrow complex. Or fusion bit, this narrow complex, wide complex may fuse together from fusion complex. Right? And second thing is very specific, left rabbit ear. That means in the RSR pattern, your left limb is more than the right limb. That is called as left rabbit ear. That is very specific for the VT. Right? Right? So if you able to remember, very good, it's good thing. If you cannot remember, at least I will take some points. That points you have to remember everything. What are those points? The thing is extreme northwest axis. This is the point. Based on this, you are differentiating. And second thing is positive or negative concordance signs. V1 to is either positive or negative. And other is left rabbit ear sign. Very important thing. And capture beat and fusion beat. At least if you say these 5 points, yes, you are good. Okay. Please at least remember these 5 points. And remaining things we'll see. So let us see how VT appears. Is it okay? Every point you understood? Anything you want me to explain again?
No, sir. It's good, sir, but the PPT in which you sent, this slide got cut actually.
Is it? I don't think so.
I mean, okay, sir, no problem. I'll take screenshot.
Okay. The same. Okay, any differences in it, just let me know. Okay. Right. So let's see this ECG. Okay. Everyone able to see this ECG?
Yes, sir.
Okay, able to see the ECG?
Yes, sir. Yes, sir.
Yeah. Someone please
Yes,
mute.
sir.
Yeah. Right. See the ECG now. Just read the ECG. Go in a protocol manner. Go in a some label chart only. It is tachyarrhythmia or not? Tachyarrhythmia first thing. Right? Narrow complex or wide complex?
Tachyarrhythmia, broad complex.
Wide complex, right? Regular, irregular.
Irregular.
Regular.
Regular. Only one box is there. Only one box is there. Only one box is almost regular.
Yes, sir.
Okay. P waves are present or absent?
Absent.
Absent. Bus wide, regular, no P waves. So what are the three DDs you have? One is your ventricular tachycardia. Other is your AV unactive middle branch block. Okay. Or pacing rhythm is there, but pacing is not there here. We ruled out that thing. Okay. We have to differentiate these two. We differentiate the first thing when you see go for the AVR. Okay. So in the AVR, how is it? This is AVR lead.
Positive.
It's a positive reflection. The positive. This is the positive. So AVR is positive. Done. It's a more specific sign for the VT. Okay. Remaining signs I'll show you here. If you see from V1 to V6. Okay.
That notch is there at Nadir of S.
Yeah. Everything is. So from V1 to V6, you see this is your QRS complex, negative deflection. Okay. VT.
Positive concordance.
Yeah. Not negative concordance. It's again negative deflection. Okay. Again negative deflection. Again negative deflection. Again from V1 to everything is same. Everything is a negative concordance is there. Right? And second thing is if you see in the lead 3, this is the lead 3. At the nadir of the QRS complex, there's a notch that's called as Josephson's notch. Right? And you can calculate Brugada sign notch, the different thing. So what I'm saying is when you get a wide complex tachycardia, please see for two things. One is AVR positivity, other is your V1 to V6 positive or negative concordance. Thus, if these two are there, no matter what, it is a VT. This Josephson's notch and all you may find, you may not find, it's just a theoretical purpose, but these two things are clinical purpose. Right? I'm moving on to the next slide. Right.
Where is the Josephson's notch?
What?
Josephson's notch.
You're able to see or not? Josephson's notch, I'll just zoom it down. See in the lead 3, this is the notch.
Okay.
Yeah, this is Josephson's notch. If you calculate from the beginning of QRS to Joseph, it will be more than 100 milliseconds. That is your Brugada sign. Okay?
Okay, sir.
Right.
Sir, you told 2 points. One is AVR positive. Then what else you told?
Other is positive and negative concordance. These two are very specific.
Okay, sir.
Right? Okay. Now let us go to the next ECG. Identify this thing. Go in a sequence. Tachyarrhythmia or not? It's a tachyarrhythmia. Broad or narrow complex?
Tachyarrhythmia.
Broad complex. Regular.
Regular.
P waves present or absent?
P wave absent.
Absent.
Yes. Plus. So wide complex tachyarrhythmia, regular rhythm with no P waves. You are thinking VT. So now you see go for AVR.
AVR positive.
Yes, very good. AVR is positive. Done. There itself diagnosis done. VT. You can go for V1 to V6.
No concordance.
No concordance is there, but still okay. Fine. Here I am showing you one sign. See this thing. It is looking like a bundle branch block, but left is bigger than the right. Can you appreciate this thing?
Yes.
Left is bigger than the right. That is called as left rabbit ear. Again, a specific sign. Left rabbit ear. Right?
Left rabbit ear, it is for VT.
It is for VT. Normal RSR pattern in RBBP, we see this is the RSR pattern. How it is? This is RSR pattern. RSR. That is your RBBP pattern. But in VT here, big left limb, then small left limb. This is the thing. Big left limb and small limb. Okay? That is left rabbit ear.
Sir, please show Brugada sign here.
Brugada sign. Here you can see, that's what I'm saying, Josephson's notch and Brugada sign. Maybe you can see, you cannot see, but these two are very specific I'm saying. See here, you cannot see the Josephson's sign and no notch is there. To see, yeah.
So that concordance, discordance, I didn't get it. Can you
concordance, I'll say this one. If you see this ECG, the previous ECG, if you see this one, from V1 to V6 if you go, this is your QRS complex, this is your T wave. Okay? Again,
Yes, sir.
that is negative QRS. If in V3, again negative QRS. Okay.
Yes,
In
sir.
V4, again negative QRS. V5, again negative QRS. V6, again negative QRS. So QRS complex from V1 to V6, it should be negative or positive. It should not be
Okay.
mixed. Okay, if it is negative means negative concordance, if it is positive means positive concordance.
Okay, sir.
Right? So here, even though if you see here, this is your QRS complex, it is positive in V1, positive in V2, positive in V3, okay, some are positive in V4, but V5 is become negative. But even then, we have this left rabbit here and AVR positivity. Based on this, we are diagnosing it as VT.
Okay, sir.
Right? So that's what about this thing. Now you let's identify this time. Identify what is this thing. Wide complex, narrow complex.
Wide complex.
So wide complex, regular, no P waves are there.
Regular.
No periods.
Okay. Go and see AVR, what is it?
positive.
AVR
Yes.
positive.
AVR is
Concordance.
positive. That is VT. Okay, again also if you see negative concordance, this is your QRS complex, positive, negative, again positive QRS, okay, positive, negative, again became. So concordance is not at all specific like this, but AVR positive is very specific. That's what I want to mention.
Yes,
Okay.
sir. Sir, and here left is more
There is
than
no
right.
left
Yeah,
ear
yeah.
rabbit.
Here, see, this is one more important. Let's say come this ECG. What we study is left rabbit ear again, but it's not left rabbit ear. Left is small.
Right.
When you compare this thing, right? Here right is big. When you see here right is big, but still we are saying VT because AVR is positive. So out of all the saints you study, AVR positive is the specific thing. Okay? Right. So again, I am going back to the same slide. Please, if you don't have this slide, please write down this slide. Whatever the 5 points I kept is 5 points is very important. Out of all the points, AVR positive is very important. Right? So again, I am saying when you want to say the VT, definitely you have to have wide QRS. After wide QRS, you will have AVR positivity. Very important. Okay. After this, you can see from V1 to V6, it should be either positive concordance or negative concordance. Okay. Then you can say for your capture beat is very important, your fusion beat is important. These 5 points you have to say for the exam. All these 5 points. Done. If they are more excited to you, then they can ask you what is your Josephson's notch, what is Brugada sign, what is left rabbit ear, they will ask. That's for theoretical things. But these 5 points are very important. Right?
Yes, sir.
This is the question even enter for the JIPMER interview also for SR. The first question they asked is how do you differentiate VT from SVT turbulence? This is the first question they got. So very famous central institute question also. Okay. Right. So after knowing this, we have to know what is polymorphic VT, what is monomorphic VT. Right? So monomorphic VT means name itself is monomorphic. Everything is same. Or if you see here, same morphology. All with same morphology. QRS, very same morphology. All the QRS complex. So polymorphic means different morphology. So what is different morphology? The QRS complexes may differ either in the size, amplitude, either in the axis, either in the speed, anything they can differ. That is called as polymorphic VT. So this is the definition I am writing here. So there are multiple ventricular foci. Okay. With the resultant QRS complex varying in amplitude or axis or duration, anything can happen. Right? For example, just a minute. Again, there are so much thunderstorm is there. Maybe I think it will rain now. If there is any power cut, please don't leave the class. I will come back within 5 minutes. Please take 5 minutes. Okay? There is so much thunderstorm is there. I don't know why. Right. So polymorphic VT again here QRS complex should be different morphologies there. For example, this is the QRS complex. This is the QRS complex. Other thing is very small QRS complex. Big QRS complex. Right? Similarly, duration also. One is very big, wide QRS complex. One is some narrow QRS complex. Like that. So the morphology will be different either in the amplitude or the duration or in the axis. That is called as polymorphic VT. Right? Understood this definition? I will show you the examples also. And what is torsadis points? The same in the polymorphic VT. If patient has some long QT, that is called as torsadis point. Okay? If polymorphic VT occurring in individuals of QT prolongation, that is called as torsadis point. Okay? Let us go for the examples. Right. You see this ECG now? Right. 1 minute, I will zoom it up. Right. You can see the ECG here?
Yes, sir.
Yes,
Yeah.
sir.
Again, if you see normally some going on, suddenly some impulse has come from here to here, some impulse has come. Okay, it's almost wide QRS only, but again here some QRS are not regular, some low amplitude is there, again some low amplitude is there, again low amplitude, different amplitudes are there. So that is called as polymorphic VT. Right? This is your polymorphic VT because you can say QRS complex are usually they are differing in the amplitude. Right, here also again if you see this very big QRS complex is there until here. Here only some small amplitude QRS complex is there. So different amplitudes are there, you can say it's polymorphicity. Right? Easy to identify, no issues. If the QRS complex is completely regular, they are monomorphicity. If they're differing in the shape, differing in the amplitude, differing in the duration, you can say it as polymorphicity. Right? Okay. Now let us identify this thing. Wide complex and narrow complex.
Wide
Wide.
complex
Okay.
and varying amplitude.
Yes. Simple.
So it is polymorphicity.
See this thing. This is the QRS complex, QRS complex, QRS complex. Here it is amplitude is small amplitude. You can identify small amplitude one. This is a big amplitude one. Okay. Okay. When you see the duration also here, number of small boxes are very a bit more. When you compare here, small boxes are less. Duration also is different. And that is called as polymorphicity. Either duration can be changed, or axis can be changed, or amplitude can be changed. Clear?
The AVR is negative in it.
What?
You
This is
say
only
That
Yeah,
is
this is only-
normal pattern.
no. This is only just this until here is normal pattern. Suddenly he developed VT here now.
Okay.
Until he is normal sinus rhythm only. Suddenly he got VT. Okay.
Okay.
Right. If you see this thing again, if you see properly, one more point I want to mention here. You see the QT interval here. I will just zoom it up. What is the QT interval? You just see here. Right. This is the P start of the QRS complex is here. Okay. Until here is the QT interval. It's definitely more than 10 small boxes. So in a polymorphicity, you found long QT interval, that is your torsionality points. Okay.
Sir, polymorphic VT and torsionality point is one and the same thing.
Same only. If a polymorphicity position, polymorphicity happens in background of long QT, that is called as torsionality points. That's it. Okay. Polymorphicity can be happened by anything, any articular disturbance, anything can cause, any structural abnormalities can cause. But if it happens in the background of already patient is having long QT interval, then you can call it as torsionality points. That's it. Okay. Simple.
Yes.
So your basic point is first you identify the VT, then you identify whether it is a monomorphic or polymorphic. After identifying in the polymorphic, go and see the QT interval. If the QT interval is prolonged, it is a torsionality point. That means patient is more chance of developing VT again. You have to definitely give definitive management for this patient. If there is no long QT, that means you have to identify what is the cause. Is there some structural problem or some electrical metabolic problem? You have to see that. That's it. Okay. Right. So clear this until this is clear everything.
Yes, sir.
Yeah, right. No doubts. So let us, before going to management, just see this thing.
Sir, 51st slide.
Which one?
51
51.
slide.
I don't know what slide is going on now. This is on this one.
Not this. Sir, here, this one.
This one.
Yes, sir, after this.
After this one.
Sir, here right more than left
Yeah, that only I'm saying right more than. I just showed you the exception. There are different features of VT I explained to you. But left more than right, positive concordance, negative, all these things they will say. But out of all these things, your specific finding is AVR positive. Okay.
Okay.
For studying purpose, you study left concordance. Most of the times you will get left concordance, positive, negative concordance you will get. Left rabbit here you will get. Even if you don't get, if AVR is positive, it's more specific, you will label it as VT, I am saying. That is it.
Okay, sir. But this this ECG, right is more than left or left is more than right, sir?
Here right is more than left. Just like RPVT is there, it's like same only.
Okay, sir. Okay, sir.
Like RSR pattern. Right?
Yes,
This is more than left. Okay.
Okay,
Right.
sir.
So before going to management, I am telling you again, if there is any wide complex tachyarrhythmia, okay, you have to identify whether it is a regular or not. P waves are absent, then it can be either VT or it can be AVNRT with bundle branch block, okay, or AVRT in antidromic pathway, very important, and then it can be your pacemaker rhythm. Okay, please rule out tricyclic antidepressant poisoning, that is a triplet. Then you can rule out your potassium hyperkalemia. Then you can go for the pacemaker. How will you identify pacemaker? Again, there is a vertical slit, then QRS complex T. Then again vertical slit, QRS complex T. Like this, if you have this vertical slit is a pacemaker rhythm. If it is not, it's not a pacemaker rhythm. Right? Then you have to identify whether it's a monomorphic or polymorphic. So how will you identify monomorphic, polymorphic? Vary in amplitude, duration, and axis also. Then you have to identify whether it's a torch identity points is there or not by seeing your QT interval. This is the protocol. Okay, please always try to habituate the way you are going in a protocol manner. Then even in the sleep also it's very easy to do. Right? When you are doing duty in SR or somewhere also, suddenly PGs will come, bring you the ECG. You just say like this, you throw like this. It's torch identity point. It's some long QT syndrome. It's some wide complex ventricular arrhythmia. You can leave it like that. It's AV with the ventral branch block. Just you go in a flowchart manner. Right? So step by step you go. So after this we'll go for the management here. All the management we'll discuss right now. So now you're able to identify all the ECGs. Arrhythmia pattern ECGs you can identify. Definitely one arrhythmia ECG will be there in the OSCE, no matter what. Okay. If examiner is very generous, he will give AF. If he is not generous, he will give AVNRT. Or if he is not generous, he will go for polymorphic VT and torsitis also. Right? AF and VT are very stand mod. They will give definitely OSCE. And after this thing, you know all the table by is there. In table by definitely everyone want to ask ECGs. So definitely it's again fetching mark. So after identifying ECG, we have to know what is the management. Very important. So knowing is not important. Again, managing is important. So all the management of tachyarrhythmias we'll discuss at one shot. Right? The first gold standard. Even in the OSCE questions. Just see this thing. If patient is unstable, you have to shock the patient. Okay? If patient is in shock, you have to shock the patient. What is unstable here? Patient is having hypotension or patient is having acute pulmonary edema. Okay, these two things are there, then definitely you have to go for shocking only. There's nothing, no need to remember any drug also. Just see the entire question in the OSCE, they give the ECG, some VT is there, just directly go and see the vitals. If vitals BP is 80 by 60, 70 by 50, 90 by 60, happily directly shock the patient, no drug at all. Right? Similarly, if patient is having pulmonary edema, some Killips class 3, grade 3 crepitations are there, yes, you can go for the shocking, DC conversion only. Right? That is what is called as your electrical cardioversion. You have to, okay, simple, profound. But if the patient is stable, then you started your headache. Right? In the stable, you have to identify whether it is a SVT or a VT. Right? In the VT also, whether it is a mono or poly. Right? In the SVT, you have to identify whether it's a AF or it's a AVNRT. Very important. All these things you identify, then you can go for the management. One by one we'll go. First we'll go for our SVT. Right? Right. We'll go for the SVT management. Right? In the SVT, the first thing is any ECG they will have PSVT is there, like paroxysmal supraventricular tachycardia. Simple, it's a narrow complex, regular, P waves absent. Yes, usually the first drug you are giving is, what is the drug you are giving here?
Adenosine.
Very good, but not. The first thing you have to do is vagal maneuvers. Very important. Okay. First step is vagal maneuvers, but drug of choice is adenosine. Okay. Adenosine is again very important. They are asking some questions and all. It is short-acting antiarrhythmic. Just few points you have to remember here. Adenosine first starting dose is 6 mg. If it is not relieving, then you can give one more dose 12 mg. Then again not relieving, then you can go for one more 12 mg. That's it. Only 6 mg, 12 mg, 12 mg. That's it. There is no other further dosing. Okay. In American guidelines, they are saying you can go for 18 mg, but our Indian guidelines we are not following. Only simple thing: 6 mg, 12 mg, 12 mg. If not recurring, leave it. You can go for cardioversion or something, but no more extra adenosine. Right? Okay. One or 2 points I want to discuss about adenosine because they have put in a drug. So adenosine is a short-acting antiarrhythmic. Why it's short-acting antiarrhythmic? Because when you give adenosine, what happens is adenosine is taken up by all the cells. Adenosine uptake proteins are there. It is taken up by all the cells. So it is present in the blood for very short time. That's why it's called short-acting antiarrhythmic. Okay. So because it is taken up by all the cells, you have to give adenosine very nearer to the heart and very rapid push with flush. Very important thing. The mechanism of giving adenosine, I think everyone knows. Okay. You have to raise the. Usually you have to put cannula at brachial plexus. Cannula at the brachial vein. Right. Then you have to raise the hand. You have to flush immediately. Okay. Give adenosine, flush and raise the hand. to the heart level. This is the way you have to give adenosine. Otherwise, because it's short-acting antiarrhythmic, it is taken up by the cells. It is not taken up by the heart. It won't act. Okay.
Sir, central line, can't we give via central
We
line?
cannot give central line because what will happen is central line, it will put central line, immediately it will go to the heart, it may cause dangerous hyperkalemia also.
No.
Okay, dangerous potassium disorders are there, so that's why usually put in the brachial vein. You won't give it in jugular vein also. Right? So put it in brachial vein, then immediately you push the flush, then raise the hand. That is the technique of giving adenosine. 6 mg, 12 mg, 12 mg. Right? One more important point. Maybe they will definitely ask one important point here again. So what is the side effect?
AV block.
Bronchospasm. Right, very important, because it's a bronchospasm, it is contraindicated in patients of bronchial asthma or COPD. Right, that's it. These 3-4 points you have to remember definitely. So how the ASCII questions they're framing is they're just simply giving a PSVT rhythm. So they are saying a patient has known case of bronchial asthma, the patient is having bronchi are there. Now what is the next level of management they're asking? It is not adenosine. You have to give some other drug, we'll deal everything. So just see the question. Any arrhythmia they're giving, see the vitals. If vitals are unstable, you are giving shock. If vitals are stable, then you have to give some other drug. You have to see any contraindications are there or not. Okay? Simple. Someone who is it, some audio. Please everyone mute your audios, please. Right. Okay. Right. Now after this,
Sir, vagal manures, can you once summarize?
vagal manure, nothing is there. Initially, whenever the PSVT patient has come, what you have to do clinically is you have to do vagal manure. Just only one thumb at the carotid artery. Just you have to do slight massage like this. That's it. You should not do simultaneously both. Only one thing. If it is working out, it's very good. If it's not working out, you have to go for the drug therapy. Most of the cases, it won't work out. People, very lucky people, it will work out. Right? Okay. So this is one important point I want to mention. One more important thing I want to mention is right. So whatever it is, if SVT comes, okay, if SVT regular rhythm comes, in the first starting point of the seminar of this PPT, I mentioned only one thing. What is called as ventricular rate is important. It is not atrial rate. Ventricular rate is important. Okay. So whenever there is SVT is there, from atria your ectopic impulse are coming. It is beating at a very high fast rate. All these impulses are traveling through AV node, so they are going to the ventricle and causing ventricle to contract. So now you have to control only ventricular rate. You are not at all bothered about the atrial rate. So how to control ventricular rate? You should stop the impulses coming from the atria to the ventricle. So how will you stop the impulses coming from atria to ventricle? You have to block AV node. Okay? You understand this concept? For SVT, you have to control ventricular rate. To control ventricular rate, you have to give AV nodal blockers. Okay? You understood this concept? So whatever SVT or anything, you are concerned about the ventricular rate. That is only I told you in the beginning class of 10. Because ventricular rate is directly proportional to your diastolic filling. That directly proportional to your cardiac output. That is proportional to your perfusion of tissues. So your ventricular rate should be not so high. So what you can do here in SVT, all the impulses from the atria, they're going to AV node and going to ventricle. You have to stop impulses coming from atria to ventricle. You have to block AV node. So that is called AV nodal blockers. These are the 4 drugs are the AV nodal blockers. Very important here. Right. So what are the 4 drugs AV nodal blockers?
Calcium channel blockers, beta blockers, and digoxin in pregnancy and heart failure.
Yes. Adenosine, beta blockers, calcium channel blockers. This again we discussed in our regular class only. And digoxin, ABCD. Okay, adenosine, beta blocker, calcium channel blockers, and digoxin. Right, adenosine we already discussed. Just small points we'll discuss here. Adenosine. Right, adenosine we discussed already. The side effect is bronchospasm. Very important. Okay. Beta blockers also again the side effect is bronchospasm. Right. In the calcium channel blockers, what you are giving here, NDHPs or DHPs? You are giving non-dihydropyridines. Dihydropyridines are amlodipine, nifedipine, nicardipine. They will cause reflex tachycardia. You are not using those things. You are using only non-DHPs. That is your verapamil and diltiazem. Very important. Right? And digoxin. Clear? So adenosine, I already discussed what is the dose. There is other. Okay. 1 minute. Right. Adenosine we discussed already. The dose it is 6 mg, 12 mg and 12 mg. We discussed. 6 mg not improving, 12 mg not improving, 12 mg. That's it, maximum dose. Beta blockers mainly you are using metoprolol. What is the dose? You can give 5 mg, not improving again 5 mg. You can give 5 mg IV. First 15 mg is the maximum. 5 mg, 5 mg, 5 mg. Right? And clinically you are giving diltiazem. What is the diltiazem dose? Again, is important. Initially starting dose is 0.25 mg per kg. So roughly for a 60 kg person it is 15 mg. Right? If not improving, you can go for next dose is 0.35 mg per kg. That's it. Right? Similar digoxin, you can give only 0.5 mg. If not improving, you can go for 1 mg IV. But simple. Right? Please remember these things. Again, in the drugs, they will put adenosine, they can put diltiazem, they can put digoxin. Cardiac drugs are very famous. Cardiac drugs, anti-epileptic drugs, and your blood hematinics, all these things are very important. They will put in the drugs also. Right? Adenosine 6, 12, 12. If you are giving metoprolol 5, 5, 5. Diltiazem 0.25 mg per kg. If not relieved, you can go for 0.35 mg per kg. Then it stops. You don't need to give. Digoxin 0.5 mg. Then you can go for 1 mg. That's it.
Sir, between two doses, how long we should wait?
There's nothing. It's all short acting only. Just to give the dose and see. Within 5 minutes only you can repeat the dose.
Okay, sir.
Right. Yesterday only we did night duty again. Is a male with fast ventricular rate. He is already known case of COPD. I just gave Dilgem 15 mg. Not relieved. I gave 20 mg. Not relieved. Okay, we just kept him on Mentora infusion. Right, simple. Just you have to play with the drugs only. Right now, if you know this thing, so what the questions they are going to ask is, right? Okay, just see how the questions they are framing in the case of SVT.
Which infusion you gave, sir?
Mentora only. We'll discuss this. AF now we'll discuss again. Okay. Right. So how the questions are asking is in ECG they are showing SVT. Very rarely they will ask you to identify it's AV or AVR. It's just for theory purpose. To identify, you keep it with you, no problem. But they are asking SVT. What is first step? First step you are doing your vagal maneuvers. Okay. The second step is adenosine only you are giving. Right. But see the history. If there is any bronchial asthma or COPD, what you can give? Now what is the drug of choice in bronchial asthma and COPD?
Calcium channel blockers.
Yes. You cannot give adenosine. You cannot give beta blockers. The only thing you can give is diltiazem. Okay. See the question properly. Nothing. They're just mentioning COPD, bronchial asthma, or anything, or just is having diffuse bronchi. You are not giving adenosine. You are not giving beta blocker. The only drug left over is diltiazem. Okay. Now one more question they're asking. So what they're asking is usually digoxin we are not using. Okay, but the only indication of digoxin in the clinical practice is in pregnancy. Very important crucial point. Right? If any pregnant patient developing SVT, you cannot give adenosine, you cannot give metoprolol, you cannot give diltiazem. All these things are contraindicated in pregnancy. The only drug which is safe in pregnancy is digoxin. Okay. One more important point again. If any SVT with heart failure, the drug of choice again digoxin. Why? Heart failure is there, you cannot give beta blocker, you cannot give calcium blockers because they again decrease your inotropic effect on the heart. The only thing in digoxin, it has inotropic, positive inotropic effect. Because of that, you are giving in SVT with heart failure. Right? Simple things. If any patient SVT is there, if he is pregnant, you are giving digoxin. If he is in heart failure, you will give digoxin. Otherwise, there is no indication of digoxin only. Bronchial asthma, COPD, you are not giving adenosine beta blockers. You are giving calcium channel blockers. Right? Clear? Simple.
Yes, sir.
Yeah. So just see the question every time saying just see the question. If patient is in shock like hypotension, if patient is in acute pulmonary edema, you have to give cardioversion only. There is no other option available. Right? If patient is COPD or if patient is bronchial asthma, you have to give only diltiazem. There is no other option available. Right? If patient is in heart failure or if patient is in pregnancy, you have to give only digoxin. Very simple. Nothing else is there. They are just manipulating the question. It's very easy thing. You just see your work is only one thing. Identify the ECG. Right? Second thing, see the clinical status of the patient, unstable or stable. Third thing, see the comorbidities. That's it. Then you can decide the drug. Only 4 drugs are there, ABCD. You can play with those drugs. And doses are very important. Diljam 0.25 mg per kg. So usually one more thing they'll ask is diljam. If you see the diljam here, where I will write, okay. If you see diljam, it is usually vial contains 5 ml. Okay. Each ml has 5 mg. Each ml has 5 mg. That's very important. Again, that's the drug they will put for you. Diljam. Vial contains 5 ml. Each vial has 5 mg. Usually you are giving 15 mg for 60 kg patient because 0.25 mg per kg you will give 3 ml. Yesterday we gave 3 ml only. Okay. That's it. Rest was nothing. Fine. Clear? Right. This is all for the SVT with regular rhythm. Now comes our hero in casualty everywhere. That is your AF. Okay. How do you manage AF? Very important again. Right, again this same ECG they will put mostly if examiner is generous, AF ECG is definitely there. The management is very important. So what they are doing is the first thing is patient is stable or unstable. You have to see if patient is unstable. Again simple, no need of longer inhibitor, give cardioversion. If patient is unstable, very easy. You don't need longer inhibitor dose also, give cardioversion. That's it. Right, now if patient is stable, then rate comes. The first thing you have to do is rate control. Rate control, very important. Rate control. Why rate control? Because the patient is having palpitations, patient is having failure because of the patient is having problem because of the rate. You have to control the rate control. So what are the drugs you can give again? Rate control. Again you have to give AV nodal blockers only. Okay. So what are those drugs? Adenosine, beta blockers, diltiazem, calcium channel blockers. Again digoxin. Okay. Usually you don't use adenosine for the. Usually you won't use adenosine for AF. Okay, only the only indication of AF is only SVT, that PSVT only. Otherwise, you don't use anything because very short acting. Also, you don't use that thing. Usually, you go for the beta blockers or calcium channel blockers based upon the comorbidities. If COPD, bronchoplasma, you will go for calcium channel blockers. If nothing is there, you will go for beta blockers. Okay, right. Second thing you have to give is anticoagulation. Very important again. This anticoagulation, you are doing charge to vascular. I think everyone knows this thing. I don't need to repeat this thing. C is your heart failure, congestive heart failure, hypertension, AS, diabetes, stroke, any vascular event. Females usually have 1 point. Okay. If score is more than or equal to 2, yes, you have to give anticoagulation. Very important. Okay. Right. In the anticoagulation again, you have to see valvular. This AF is valvular AF or non-valvular AF. Right? If valvular AF, nothing works out, only warfarin. Okay? If it is a non-valvular, yes, you can give warfarin or novel oral anticoagulants, dabigatran, exaban, rivaroxaban, apixaban, anything you can give. Okay? Very important. Very important. Right? Anticoagulation based on charge to vascular, you have to give anticoagulation. Just see it's a valvular AF or non-valvular AF. It's a valvular AF, no anticoagulation work. You have to give only warfarin. If it's a non-valvular AF, you have to give, you can give either warfarin or novel oral anticoagulants. Nowadays, because warfarin monitoring is very difficult, toxicity is very high, you are going for the dabigatran, rivaroxaban, apixaban, all these things. Right? So here I cannot discuss all the drugs, there is no much time. So what I am suggesting you is, before going to exam, definitely heparin you have to study. Okay? Anticoagulants you have to study. No matter what, you have to study these two drugs, cardiac drugs also. Right? These two drugs you have to study. Clear. So after you did rate control, you give anticoagulation. Then next, what is the thing? Right. So one important point I want to mention here is antiarrhythmic drugs. Antiarrhythmic drugs. Okay. Usually in AF, you won't directly go for the antiarrhythmic drugs. First, always is the rate control plus anticoagulation only. Right? If after giving your maximum medical therapy, if rate is not controlled, then you can go for your anti-arrhythmic drug, that is your amiodarone drug. Okay, that is your amiodarone. Okay, so what are the indications of amiodarone? The first thing is, if there is a recurrent AF, you have to give anti-arrhythmic drug. Right? Second thing is uncontrolled rate. You can give this thing definitely. And one important point is this amiodarone has no role in valvular AF. For example, any patient of some mitral regurgitation is there, rheumatic heart disease is there, already valves are damaged, already ectopic focus is there, already it's generating arrhythmia, you cannot return back to sinus rhythm, you cannot bring it back to sinus rhythm. Okay, it will be there only. Your aim is to just control the heart rate, that's it. Right? Simple. Right? Okay. This clear? So usually you will continue rate control, you will give anticoagulation only. When you will go for antiarrhythmic drug in acute conditions, if you are unable to control the rate or if it is recurrent AF, you will control everything. Otherwise, after this thing, after some 3 weeks of anticoagulation, you can go for the antiarrhythmic drug. That's it. Here, one important point they can ask you here is, usually in our Indian medical system, it's not there. Some hospitals are not there. But usually in the case of acute conditions, you have shortest acting antiarrhythmic ibutylide. That is also class 1C drug. But mostly we are using your longest acting antiarrhythmic, that is your Mentora. Both are potassium channel openers. Again, antiarrhythmic drugs. Without studying this drug, the classification of anti is very important. I cannot have time to discuss class 1, class 2, class 3, class 4, class 5. Sodium channel blocker, beta blockers, potassium channel openers, okay, calcium channel blockers, and miscellaneous drugs are there. Study the classification of antiarrhythmic drugs definitely. Right, clear? So this is the management of AF. If it's a stable patient, if unstable, go for shock. If it's stable patient, control the rate. For rate control, only you are using metoprolol or calcium channel blockers. Right? Similarly, if anticoagulation is there, CHADS to VAS score, if more than equal to, you go for anticoagulation. If it's a Wagner AF, only warfarin. If it is non-Wagner AF, you can go for warfarin or your oral anticoagulants. Then rate control, only in the case of recurrent AF or unable to control the rate, you can go for the Mentora. Right? Right. Okay. An important point. So now let me ask this question. This is one of the question previously they asked. They showed ECG of some 54 years female patient. She came with the thing. She has narrow complex tachycardia, irregular, no PVS are there. The patient is having some pulmonary edema also. Tachypnea is there. Okay. BP is stable, 120/17. What will you do? What drug you will give to control the rate?
Shock will be given because patient has pulmonary edema.
Okay, patient is pulmonary edema, given shock. If patient is just only heart failure, it's not a pulmonary edema. Like, see, pulmonary edema, heart failure, so many things. So just only by crepitations, you don't go for pulmonary edema. If they say like saturation is less, tachypnea is there, all these things comes under pulmonary edema. Okay, if saturation is normal only, just only crepitations are there, he is just having left heart failure. Then that condition, what will you do?
Digoxin.
Digoxin, that's a very important thing. If AF with heart failure, digoxin. AF with pulmonary edema, AF with shock, cardioversion. Okay, pulmonary edema means they will mention definitely patient is having a hypoxia, saturation is very less. Okay, he is unable to take the breath. Like the acute condition, you have to give shock. Normally, crepitation says it's not pulmonary edema, it's just a left heart failure, you can go for digoxin. Please don't get confused. Okay. Right. So this completes the management of our SVTs. Okay, what is
Sir,
this thing? Yeah.
Recurrent AF means within how much time it will come?
Recurrent AF means yesterday. Recurrent means suddenly you already given. This is not an acute condition. Like normally you have given the patient reverted. Again he is coming. Within 7 days it's not at all improving. Then you can go for Mentora only. This is just only for the thing. Okay. Okay. One more thing.
Sir, any change in amiodarone dosing, sir?
Amiodarone dosing we will discuss. Amiodarone usually what is the dose you are giving Amiodarone?
Initial 150 followed by
150 loading.
Yeah. Okay. Usually 150 mg loading dose, then followed by 1 mg per minute for 12 hours, then followed by 0.5 mg per minute for next 6 hours. Like that you want to give. Okay. But in the case of your cardiac arrest, if it's a cardiac arrest, how much you are giving?
Repeat 150 followed by repeat 150 followed by 300.
No, in the case of cardiac arrest, CPR basic life BLS protocol, after if it is a shockable rhythm, after giving 3 shocks, you have to give Mentora of 300 mg. That is a loading dose. While doing CPR, if your this ACLS is showing shockable rhythm, you give shock also 3 times. Patient is not reverted, then the dose of Mentora is 300 mg. Very important. There it is. Okay. Right.
Sir, your yesterday's patient, you used amiodarone because rate was uncontrolled.
Because rate was uncontrolled. We have given already complete full dose of digoxin. We cannot give metoprolol. Sorry, we give full dose of the diltiazem we have given. we cannot give metoprolol. Rate is not controlled, still it is 160, 170. So we start on ephedrine. By morning, the rate is controlled. It's not reverted, but rate controlled to 110.
So how much we will tell the rate is controlled?
Rate, it should be below 100, but okay, 100 to 120 will be fine. It should be below 100 actually. Target is below 100.
In that case, amiodarone oral should be continued to control the rate.
Yeah, we have to continue the rate. We can basically after giving amiodarone infusion, usually you put on a tablet of rate control. Like I kept on tabletizing only. Okay. That's what again if it's a valvular AF or non-valvular AF. If it's a valvular AF, you cannot bring down the sinus rhythm. There is no point of giving antiarrhythmic drug. If it is non-valvular AF, okay, you can bring down the rhythm. You can give amiodarone again oral.
I have one more doubt regarding charts
AF is
for
very controversial thing. Yeah. Then.
regarding the charts was for similarly like for valvular and non-valvular AF, which one should we calculate charts was, and then which type of AF charts was is not useful?
See,
because during rounds, one of my colleagues told I am confused actually. One type of AF, there is no need to calculate charts was.
that is called lone AF. What is called as lone AF? Lone AF is only AF is
Without
there.
any structural abnormality.
Yeah, lone AF means there's AF is there. There's no left atrial enlargement is there. There's no left atrial enlargement. Okay. Suddenly thyrotoxicosis patient having AF, or suddenly in hospitalized patient having AF, suddenly alcoholic withdrawal patient is having AF. So then you can go. No need to go for that. So just if you give rate control, it will come back because of sympathetic surge only it is. So then no need to give any anti-charge to us and all these things. But if patient is having left atrial enlargement is there in echo, that means he's having some long-standing AF only. Definitely you have to calculate charge to us and you have to give anticoagulation.
Okay.
Only in the transient condition is called lone AF with no left atrial pathology. Then you can no need to give like thyrotoxicosis, one is alcohol withdrawal, catecholamine surge conditions, right? Okay.
And otherwise, valvular AF as well as non-valvular AF,
You have to
we
give
have to calculate
anticoagulation.
charts first.
Yes, definitely you have to give anticoagulation. Okay, the main aim is you have to prevent thrombus formation and you have to prevent your embolic strokes. Okay, right. So don't get so much confusion and all. See the questions properly. If patient is unstable, go for your cardioversion. If patient is stable, see the comorbidities. If bronchial asthma is there, don't give metoprolol. Go for calcium and blockers only. If patient is in failure, go for digoxin only. The first step is rate control only. Next step is anticoagulation only. If it is valvular, non-valvular. Valvular, only warfarin. Non-valvular, anything you can give, right? Then you can go for antiarrhythmic drug if rate is not controlled. If the patient is having recurrent AF, then you can go for antiarrhythmic drugs, right? Okay. Then just we already discussed only. Can you identify the ECG? Yeah.
One more doubt. Sir,
Yeah.
amiodarone infusion should be given in 5D only.
Yeah, 5% extrasonic because it is not compatible with the NS.
Okay, sir. And if
There is
patient
no
is
point in
like
giving NS.
diabetic and all, still we should give in 5D only.
Still fighting. It is not compatible with NS. There is no point in mixing in NS. Okay, what is ECG?
Narrow complex tachycardia.
Narrow complex, very good. Next,
No P-wave, regular.
very good.
Regular.
This is P wave.
No
This is your P wave. This is your P wave. This is P wave. This is P wave. This is P wave. Everywhere P wave is there.
But morphology is different.
What?
3 types of morphology of P waves is seen.
There's no 3 different morphologies also. Very 3 different. It's just sinus tachycardia. That's why I kept this ECG. It's just sinus tachycardia. Okay.
Okay.
Nothing else. Okay. Then identify this ECG. Fast. We can go. Let me do
For narrow complex tachycardia, it is irregular.
testing irregular. So mostly AF.
Irregularly irregular.
Irregular. AF only. Sometimes you may see P waves. Okay. You can see everywhere here is only just 1 or 2 boxes. Here some 3 boxes irregular. Narrow complex. There's no point irregular narrow complex. AF only. No need to think much. Okay, na? Okay. Then you go for this thing. Oh, sorry. What is this thing?
Narrow complex and regular, and there is
Yes.
no P wave. It is
Oh.
SVT.
PSVT okay or SVT okay. Now, can anyone say AVNRT or AVRT? What do you think? Fast. No one?
AVNRT.
Which one?
P wave is just after QRS.
Excellent. This is the P wave. It's just after the this one. This is just after the QRS complex. You can see in lead to as a negative deflection. Okay, this one.
Okay, sir.
Okay, AVNRT. Very good. Last and final. Oh, this one we discussed already. Okay, this one we discussed already. Okay, VT. You know, don't say no problem. VT. Okay, then comes okay. This completes the arrhythmias. Oh, we didn't discuss the management of VT. Okay, we'll discuss the management of VT. So SVT we discussed properly, all the SVTs and all we discussed everything. Then we come to the VT management. Okay. So how will you manage the VT? Again, same. If patient is unstable, like any shock or anything, go for shock. Right? Now if patient is stable, then again comes a problem. Okay. Please make a 3-type flowchart. One is monomorphic VT, other is your polymorphic VT, other is your digoxin induced or myocardial infarction induced VT. Very important. Right? Monomorphic VT, you have to give antiarrhythmic drug only, that is your Mentora. Right? Polymorphic VT, you have to give drug of choice, magnesium sulfate, very important. And digoxin induced or MI induced VT, you have to give lidocaine or lidocaine. It is 1.5 mg per kg dose. Right? That's it. Clear? Right, to
Sir,
identify the
digoxin thing you repeat, no, sir?
So you saw the VT and all. VT can be happen because of structural defect or can be happen because of side effect like digoxin or maybe because of MI leading to scar tissue that is causing VT.
Okay.
Okay. So if digoxin has a side effect of causing VT, you have to give lidocaine. If MI induces VT, you have to give lidocaine. Usually you don't see. Again, this lidocaine you are giving in the case of basic life support in the ACLS guidelines. After giving quadron, the next step is you are giving lidocaine. Right, in the ACLS guideline, you are putting your shockable rhythm, this one, this spacer. If they say like shockable rhythm, you shock, shockable rhythm, you shock, shockable rhythm, you shock. 3 times you gave the shock, then you are giving Emetron 300 mg stat, then you are giving, if patient is having previous MI, if patient is taking digoxin, you are giving lidocaine also 1.5 mg per kg. Very important. Okay, so simple. Identify the VT, whether monomorphic, polymorphic. Monomorphic you are giving Emetron only, polymorphic you are giving magnesium sulfate. Simple thing. Right, then Emetron again 150 mg, then 1 mg per minute, then 0.5 mg per minute. Simple. Okay, I think it's polymorbidity or giving magnesium sulfate only. If it's a long QT interval, please try to avoid the drugs causing long QT interval. Done. So this completes our tachyarrhythmias. So any doubts? Please after this class don't miss ECG, don't miss diagnosing ECG. Okay, not in the exam, for the practical class I'm saying. Okay, it's very easy thing. Just if you go through the proper protocol, narrow complex, wide complex, regular, PV present, PV absent. Okay, if you go like that, it's very easy. Even in sleep, you can diagnose. Okay, let's move on to next thing. Right. So after this, we are going to MI, myocardial infarction. Okay, can I go? Any doubts?
Yes, sir.
Right. So MI also we know almost all the things, but some points are very important. Those points I will cover. Remaining things you know already. Whenever you are saying any ECG, if you are thinking MI, you have to identify 4 things. One is what stage of MI it is. Second thing is what type of MI it is. Third thing is what region is getting involved. And fourth is what are the reciprocal changes. We have to confirm MI with reciprocal changes. Very important. This point is very important. If there are no reciprocal changes, we cannot confirm it as MI. Reciprocal changes should be there. So we'll discuss what is this. Right?
Yes.
Okay, any issues with audio? Right. So let us see what is the stages of MI. There are 4 stages of MI are there. Okay, hyperacute, acute, subacute, and chronic. So how will you see in ECG? In hyperacute, this is what this question they are asking us on different stages of MI. You will see hyperacute, you will have tall T waves. You don't have any ST elevation, you will have tall T waves. In acute, you are having ST elevation. So you'll have ST elevation. In subacute, you'll have ST elevation plus T inversion. You'll have ST elevation and T inversion. And chronic, you'll have pathological QS, not physiological QS, pathological QS. This is the evolution of the MI. Okay, you'll have pathological QS. Clear? So 4 shares hyperacute, acute, subacute, and chronic. Hyperacute, you will see all T waves. Acute, you will see ST elevation, and subacute, you will see ST elevation, T inversion, and chronic, you will see pathological Q waves. So let us see this thing. This is the evolving stages of MI as I discussed. This is a normal P, Q, R, S, T. Okay, within seconds there is no ST elevation, just only some T wave is elevated, hyperacute T wave. Okay, after this you have ST elevation. You can see ST elevation. This is the baseline. There is ST elevation. This is J point elevation. That is ST elevation. Then you will see ST elevation and T inversion. Then you can see pathological Q waves. Understand? Clear?
Yes, sir.
This is the evolution of MI from the hyperacute to chronic. That is why in always MI and all time is heart. Very, very important. We have to consider the time very important. Right? This is the first question you asked. Once you see the ECG, you are seeing MI, you have to see hyperacute, acute, subacute, chronic based on the ECG changes. That's the first thing. The second thing is see this ECG. First, we will see all ECGs. 1 minute.
Hyperacute T waves.
Yeah. Oh, sorry. Yeah, see this thing, there is no ST elevation here. Okay. P, Q, R, S, no ST elevation, but T waves are hyperacute T waves. Hyperacute T waves. Okay. This in V4 you can see properly. This is on QRS and hyperacute T wave. Okay. That is the one. Then
Hyperacute T waves and early repolarization, how to differentiate, sir?
hyperacute T waves and
Early
early repolarization will have ST elevation also.
Okay, sir.
Okay. Okay. 1 minute. See this thing, then you have ST elevations. Okay. This is a ST elevation. Your ST elevation is there. ST elevation is there. ST elevation is there. Okay. Then you can see this is the chronic MI. You can see the Q waves, pathological Q waves. Okay. Okay, V1 Q waves, Q waves, Q waves, Q waves, Q waves, Q waves. Clear? So by seeing the ECG, you have to know whether it is a hyperacute, acute, chronic, or subacute. That part is clear. Right.
Yes, sir.
Okay. That is clear. Okay. So then you go for what's the type of MI, whether it's ST elevated MI or whether non-ST elevated MI or STEMI equivalent. Very important again. Okay. ST elevation MI simple. There are ST elevations are there. Usually more than equal to 1 mm ST elevation significant, you will say. Okay. But some exceptions are there. You don't need to discuss right now. And ST non-ST means there is ST depression of 1 mm. We usually consider it as a significant non-ST elevated MI. Right. Right. So one important point here. So what is this ST elevated MI? Non-ST elevated MI. Okay. ST elevated MI is mainly because of your transmural infarction. Very important. Transmural infarction. What is transmural infarction? This is your heart. This is your endocardium, myocardium, pericardium. Whole entire wall is involved. That is transmural infarction. Right. And STEMI is mainly because of subendocardial ischemia. Subendocardial ischemia. What is this thing? This is your heart. This is your ventricle here. So this is your endocardium, myocardium, pericardium. Only just this part is ischemia is there. That is called a subendocardial ischemia. Right? Very important thing. Right? ST elevated because of transmural infarction, non-ST because of your subendocardial ischemia. Right? It occurs mainly because of the complete occlusion of vessel. It mainly occurs complete occlusion of the vessel. Right? It mainly occurs because of the partial occlusion of multiple vessels. Partial occlusion of multiple vessels. Okay, because it's a complete, that's why transmural it's involved. Because it's partial, it's not involved transmural, it's subendocardial. This much is difference here. Right, theoretically STEMI is because of transmural infarction and STEMI is because of subendocardial ischemia, and transmural infarction because of the complete occlusion of the vessel, and partial because of there's a partial obstruction of the multiple vessels are there in STEMI. Right? Right. So if you see ST elevations in the ECG, ST elevated MI, if you are saying ST depressions, you are saying as ST depression and STEMI. One more important thing is STEMI equivalent. What is the STEMI equivalent? So you don't find ECG, you don't find ST elevations in ECG. You don't find ST elevation in ECG, but you still consider like, you still manage like ST elevation MI. That is called a STEMI equivalent. Very, very, very favorite hot question for the examiners. So what are the STEMI equivalents? One is your LBBB. If patient is having LBBB, if patient is having MI, that you consider it as STEMI. That means new onset LBBB. Right? Suddenly patient is complaining of chest pain. Okay, you took the ECG, there are no ST elevations, but LBBB is there. You see the previous ECG of patient, previously this ECG is normal, today only he newly developed LBBB, so it is a MI definitely. Okay, you consider it as STEMI. Second thing is AVR ST elevation. As I discussed, AVR will always be negative in the ECG. If it is a positive and also having ST elevation is there in AVR, again that you have to consider it as STEMI equivalent. And second thing is valence, I will discuss about valence. And fourth is posterior MI, that I will discuss. And fifth is deep intervals. All these five are STEMI equivalents. Okay, even though they don't look ST elevations in ECG, but you still manage like STEMI. Very, very important things. You should not miss this thing in the casualty because the patient will collapse within hours. Right? Please remember these things. It's not for the exam also, it's your clinical practice. If patient has new onset LBBB, if patient has valence pattern, if patient has AVR ST elevation, if patient has posterior MI, I will discuss all these things with you. If patient deep intervals, all these things you have to consider as STEMI equivalent. Even if you forget deep intervals, no problem. The first four are very, very important. Right? We'll discuss all these things, don't worry. Okay, so after identifying what is the different stages of MI, you have to identify what type of MI, ST elevation and non-ST elevation or STEMI equivalent you have to identify. Then you have to identify what is the region involved. I already discussed. If V1 to V4 it is anterior MI. We already discussed V1, V2, V3, V4 anterior MI. If V5 only V5 is small, lateral MI. 1 and AVL is high lateral MI, very important. Okay, high lateral. V1 to V6 is called extended anterior MI. V1 to V6, 1 AVL is called as anterolateral MI and 2, 3 AVL is inferior MI. Okay, there is no issues, I think. Okay.
Yes, sir.
Clear? Yeah.
Yes, sir.
Then reciprocal changes. So this is the way to confirm whether it is an MI or not. Very, very important thing. So how will you confirm MIs? For example, if any patient, if any part of the territory of the ventricle is undergo infarction or something, it will produce some ischemic currents that are called as ST elevation. Okay. The opposite wall will have reciprocal changes. So those reciprocal changes you have to see. So based on that only you will confirm MI. So where will you see reciprocal changes? For anterior MI, you will see in inferior lateral walls. Right? For example, anterior ST elevation is there. In inferior lateral walls, you will have ST depression. Right? For inferior wall, see for the lateral leads. Right? If 2, 3 AVF has ST elevation, you will definitely should have ST depression in the 1 and AVL. Then only you can confirm it as MI. Similar lateral wall, if 1 and AVL has an ST elevation, then definitely 2, 3 AVF will have ST depression. Right? Posterior wall and discuss further. So just reciprocal changes means effects are opposite of ST elevation. You have to see in different leads. For anterior wall, you have to check in inferior lateral walls. Okay. For inferior wall, you have to check in the lateral leads. For lateral MI, you have to check in the inferior leads. By confirming this thing, if ST reciprocal changes are there, you confirm it is say it is MI. Okay. This is confirmatory. Very important. This is confirmatory. So to read ECG as MI, you have to identify like this. It is a hyperacute ST elevated MI. Okay. Called the anterior wall with reciprocal changes in the lateral inferior wall. Like this, these 4 points you have to say. That is very, very important thing. Okay, that's what I mentioned in the first slide only. Whether it is stage, what stage of MI, that is, as we discussed, hyperacute or acute or subacute or chronic, based on tall T waves, ST elevation and Q waves. Then what is ST elevated MI or non-ST elevated MI? Definitely you have to say. And region involving anterior wall or lateral wall or inferior wall or posterior wall, very important. And then the reciprocal changes are present in which leads. For anterior wall, you have to see in the other leads, inferior leads, lateral leads. For lateral, you see in inferior. For inferior, you see in lateral. Clear? Right.
Sir, lateral matlab we have to see in V5, V6, sir, or 1 and AVL?
Yeah, V5, V6 also, no problem. But mostly, only lateral is only 1 AVL, so I am saying about 1 AVL. If V5, V6 is there, definitely 1 AVL will be there.
Okay.
Okay. Then comes lesion discussion. Okay. Okay. So one more thing I want to say here. Okay, let us see this thing. So identify the ECG fast. Fast ECG.
There is ST elevation
Lateral wall
in
MI.
Up, AVN
one
down,
and
wall L.
AVN.
See the ECG here?
Lateral.
Anterolateral with reciprocal changes in inferior limbs.
Yes, see.
Yes,
One
sir.
has ST elevation accepted.
Yes, sir.
AVL ST elevation accepted.
Yes.
Right, okay. Then V2 ST elevation, V3 ST
Yes.
elevation, V4,
Yes.
V5, V6. So V1 to V6 almost ST elevation is there. Okay,
Yes,
so it is anterolateral MI. So
Acute.
definitely you will see reciprocal change in inferior leads. 3 is in ST depression, 2 is in ST depression, AVF also ST depression. Clear?
Yes, sir.
So you can say it properly as exactly it's ST elevated MI, anterolateral or involving, and also reciprocal changes in inferior lateral leads. That's it. Example is done there itself. Okay, this is the way you have to present this.
T wave, T inversion is not there, so it is acute.
Yeah, it's acute MI. If T inversion is subacute. Okay, right?
Yes, sir.
Don't think it is a Q wave. It is RS complex, R and S. Okay, right. Identify this MI fast.
Sir, anterolateral acute MI with reciprocal changes in inferior leads.
Same only. Okay, it's again ST elevation 1, ST elevation AVL, ST elevation V1, V2, V3, V4, V5, V6 with ST depressions in 2, 3 and AVF. Okay, the same thing. This is characteristic what is called as concave ST elevations. It's also called as tombstone pattern. Okay, which you see in the case of ST elevated tombstone pattern. Right? Okay. Then come here. Identify this
Sir,
MI.
concave means concavity upwards, no?
What? Sorry, sir. Convex. Convex. Convex estimation. Okay. Tombstone pattern. Right. Then comes this ECG. Identify this ECG.
ST elevation in 2-3 AVF.
Okay.
Only ST elevation 2-3 AVS and AVL shows depressions.
Interval
Reciprocal
MI is
changes
Therefore,
in lateral leads.
Only
Okay.
AVL has.
Acute MI in inferior wall with reciprocal changes in lateral leads.
So just listen to me. Everything inferior MI is very tricky. It looks appears easy, but something different. We'll discuss these things again. Lead 2 ST elevation, yes, you can identify. Lead 3 ST elevation, you can identify. Lead AF ST elevation, you can identify. See for the reciprocal changes in lateral leads, 1 and AVL. Maybe one very minimal is there. If you see this is the baseline, this is ST depression is there. AVL, you can identify the ST depression. Okay, as you mentioned, acute ST elevated inferior MI with reciprocal changes in 1 and AVL. You can say. Okay. But now I want to mention you one thing. Whenever you identify inferior wall MI, please go and check V1, V2, V3 also. What are the changes are there? Okay, why I will discuss.
present.
Okay. So this, please develop this habit. Once you see inferior MI, go and check for the V1, V2, V3 also. Don't just blindly directly say inferior MI. Why? We will discuss in this thing. Okay. Just see this ECG again. What is there here? What is the ECG showing?
2-3
Yes.
AVL.
Inferior wall MI with reciprocal changes in lateral leads.
Right, same like previous ECG. ST elevation 2, ST elevation 3, ST elevation AVF. Okay. With ST depression in AVL, with ST depression 1, yes, you identified inferior MI. Anything else you can see?
V1, V2, V3.
So V1 and V2 also having ST elevations. That is the important thing here. Okay. So what I want to say is, if any inferior MI you see, just see for V1, V2 also. Okay. If that thing inferior MI changes plus V1 or V2 showing ST elevations plus ST elevation in lead 3 is greater than the lead 2. Very, very, very important point. Okay, you see this thing, ST elevation lead 3 is very high when compared to ST elevation lead 2. Okay, if that thing is there, you please suspect right ventricular infarction. Okay, that's the only thing I want to mention here, right ventricular infarction. So how will you confirm this thing? You can do V4R, V5R and V6R. You can just remove V4, V5, V6 and put on the right side of the chest. Then you can see ST elevations in the V4, V5, V6 also. That is called right ventricular infarction. Clear? This point is clear?
Yes, sir.
Yeah, if you find ST elevations in 2-3 AVF, yes, good, inferior MA is there. Just go and directly jump into inferior MA also. Just go and see V1, V2. If V1 and ST elevations are there, then you see lead 3 and lead 2 ST elevations. If lead 3 is more than lead 2, then you think of right ventricular infarction. Then you ask the individual nurse to take right side of the ECG, V4R, V5R, V6R. If the ST elevation, right ventricular infarction is there. So why very, very important clinical point? If there is any, one important point I mentioned here again. If there is any left ventricular MI, you should not give fluids. Very important. But if right ventricular MI, you can give fluids a little bit. Until JVP is not raised, you can give fluids. Okay. Again, in right ventricular MI, your nitrates are contraindicated. Very, very, very important point. But in left ventricular MI, pain and all is there, you are giving sorbited nitrates. But if it's right ventricular, you should not give nitrates, because nitrates, they will decrease your preload to the heart. If preload is decreased, already right ventricle is not pumping, preload is decreased, again it cannot pump, you are worsening the situation. So nitrates are contraindicated. This is a very, very clinical oriented point. Clear on this point? Okay?
Yes, sir.
Yeah. Next ECG, identify this ECG, very important here. I don't know what is ECG. Yeah, identify this ECG very good. Fast.
Posterior leads are dated.
Anyone passed?
Severe depression is there.
Lateral MI.
MI with reciprocal changes in inferior.
What wall am I? Which wall?
High lateral.
Excellent. Okay. See the one?
In inferior wall.
Yeah. See the thing? Again here it's a your base. This is your baseline. ST elevation is in 1. And again AVL, there is ST elevation AVL. Okay. Then you see the reciprocal changes in lead 2, small ST depression. Lead 3, more ST depression is there. AVF also ST depression is there. Okay. It's a high lateral MA. Excellent. Very good.
Sir, why V5, V6 doesn't have ST elevation?
V5, V6 can see this is a small little bit ST elevation, not completely. It's evolving. It's not completely evolved. It's just evolving. I just put this ECG because this is one of the ECGs of our patient. He came with chest pain only. So many people, they have missed it as nothing, no changes are there. But slowly it is a small evolution happen. Again after 1 hour, the big evolutions in completely lateral leads are there. Okay. In angiography it showed left circumflex artery blockage is there. That's what I want to mention. So please be keen. Here again, how did you confirm here? Because its reciprocal changes are there. If there is no reciprocal changes, just by seeing this change, you cannot, maybe you will miss. Because reciprocal changes are there, you are confirmed to this. Okay. Lateral MI having reciprocal changes in inferior leads. Okay. Very, very important. Don't miss such things. ECGs, MI and tachyarrhythmia should not miss. Even in the sleep, you have to see, adopt a proper habit. Go lead wise. Okay. 1, 2, 3. Okay. Any changes are there. I saw some ST elevation AVL. Achha, maybe MI. I will see reciprocal changes in inferior leads. So you can confirm the ECG like that. Right?
Sir, there is dwarfing of R wave in AVL.
Dwarfing of R wave in AVL. What happened in AVL?
There is no R wave, means hardly very small R wave is there.
Yeah. Okay. So
In
this is the
MI,
baseline. Na? This is the baseline. You can see with the P, na? This is the baseline. Above the baseline, the J point elevation is there actually. This is the baseline.
and dwarfing of R wave also suggests MI.
Yeah. So progression you are saying. Yeah. Okay. Then we can go to the other thing. Very little bit difficult. Yeah.
So wanted to ask something. Is there for ST elevated MI you mentioned it should be elevated, J point should be elevated more than 1 mm. So I've read it somewhere कि men and women में difference होता है and also less than 40 years and more than 40 years.
Yes, definitely its difference is there, but I don't want to discuss it here. It's just only theoretical point. Usually, if more than or equal to 1 mm in all the leads, you will diagnose as TB. But in the case of V2 and V3, you will see for if it's less more than 2.5, less than 2.5 men and women, then nothing to do with it. For your practical purpose, no one will ask you. I just discussed in the theory class also regarding this thing.
Okay. Thank you.
Okay, just to go with this thing, identify the ECG. If you're identifying, very happy.
Inferior wall MI with lateral and inferior both are there.
Okay, identify the ECG.
Posterior inferior.
Okay, one more point I want to say here. Now we discussed already ST elevated MIs. We are discussing STEMI equivalents. The first STEMI equivalent discussing is posterior wall MI. So let me discuss about that thing. If you see this ECG, okay, the standard dictum I will say you here right now. Okay, before going to CCG, my card is there. Okay. Let me create one slide. Right. So what I want to say is you are identifying the ECG. If you identify inferior wall MI, okay, the first thing you is check for the V1 and V2. I told already. If V1 also having ST elevation, if lead 3 ST elevation is greater than lead 2, you suspect your right ventricular MI. That is the first thing. Okay. Second important thing I want to say is if there is any inferior wall MI, please check for the V1, V2, V3 for the posterior wall MI changes. Okay. So why? Because posterior wall MI never happens isolated. It never happens. It never occurs isolatedly. Never occur isolated. It will occur along with inferior wall as infero-posterior MI, or it occurs as infero-lateral posterior wall MI. Okay, this again is standard. That's why inferior wall MI will be very tricky. If inferior wall MI is there, check for right ventricular infarction. If inferior wall MI is there, check for the posterior wall MI. Right ventricle I told you, see for the V1 ST elevation. Okay, for posterior wall MI I am saying you just check for your V1, V2, V3 in ST. What you will say. So how will you identify the posterior wall MI? I will tell you. So let us see. Normally, as I discussed, any MI is there. You are finding 3 changes are there. One is your tall T base, other is your ST elevation, other is your Q waves. Right? These 3 changes are the any changes of any MI changes you will see. Right? But for the posterior wall, what is happening? Ventricle is there, posterior wall is there. You are not placing any lead in the posterior wall. You are just placing leads anteriorly. So you cannot appreciate the ST elevations that are happening because of posterior wall. Hyperacute T waves, you cannot appreciate those things. Right? So what we can see is, you can see reciprocal changes. You can see reciprocal changes in the anterior leads. If posterior wall is getting infarct, you can see reciprocal changes in anterior leads. So what are those anterior leads in V1, in V2, in V3, right? So instead of your ST elevation, you will have ST depression here. Very important, right? Similarly, instead of your Q waves, you will have R waves here. Very important, right? Instead of your T inversion, you will have upright T waves. You understand this thing, right? If there's a posterior wall MI is there, posterior wall also develop some ST elevations, T inversions and Q waves, but you cannot see posterior wall. You will see reciprocal changes in the anterior leads. So what are those anterior leads? V1, V2, V3. Instead of ST elevation, you will see ST depression V1, V2, V3. Instead of your T inversion, you will see upright T waves. Instead of Q waves, you will see R waves. This is the triad. Okay. In V1, V2, V3, if you are seeing ST depression with upright R waves with T inversion, please suspect posterior wall MI and ask sister for the posterior lead MI, posterior lead ECG. Am I clear? Is it okay?
Yes, sir.
Yes, sir.
So let us come back to the ECG. We see the ECG right now. As we discussed, see, this is what one having ST elevation accepted, 2 also ST elevation is there, okay. Again, then 2 ST elevation is there, okay. Then ABL has ST elevation, ABF has ST elevation, Okay, so infralateral is there. You go and check for the posterior. How can you check posterior? V1, V2, V3. This is V1, this is V2, this is V3. Very important. ST depression, ST depression, ST depression. Upright R waves, okay, and upright T waves. So all these three are there. You are suspecting post-wall MI. You can ask for the V7, V8, V9. Clear? Right?
Yes, sir.
Yeah. So normally when you go from V1 to V6, your R wave will increase slowly. From V1 small R is there, so V2 small, it will increase slowly. So V1, V2 you won't see R waves. If you are seeing R waves, definitely you have to suspect post-wall MI. Right? The important question they're asking is how do you suspect post-wall MI in normally 12 lead ECG? I am suspecting based upon ST depressions mu1 V2 V3, based on tall R waves mu1 V2, and also upright T waves. Okay. So now I ask the sister to do V7, V8, V9 ECGs. Then what will happen? Let us see. Right. This is your V7, V8, V9 here. So here V7 has ST elevation, V8 also ST elevation, V9 ST elevation. I confirm post-wall MI. Clear? So this also again they'll ask just they'll put the first ECG, this ECG they can put, and they just ask what is the next step. Next step is to check for the posterior wall leads. Okay. Am I clear on this?
Yes, sir.
Yeah.
Yes, sir.
Simple thing. This is again, see in the ECG, for example, sometimes posterior wall MI they will call it STEMI equivalent, because posterior wall MI, even though ECG is not showing ST elevations, you treat it as a ST elevated MI only. That's it, the STEMI equivalent. Okay. Right. One more important thing, one of STEMI equivalent is AVR ST elevation. Okay. If you see any ECG of all these things here, AVR is ST. AVR is what is there? Negative only. Okay. AVR nothing is there. AVR will be negative, or no ST elevation is there. Okay. But if suddenly if you are saying AVR ST elevation, you should consider it as STEMI equivalent. Why? I will tell you. Okay. This is again important point. Okay. Now let us see one important point I discuss here. I want to discuss. Right. See, this AVR you are seeing from the right upper arm. You are seeing the heart from the right upper arm. Okay. When you see this is the heart vector is like this. Okay, in this direction. But you are seeing heart from the right upper arm. So that's why it's always negative only. Okay, it's always negative only. Okay. So when will you get AVR ST elevation? You will see. When you will get AVR ST elevation, there are only two conditions are there. One is there is completely subendocardial ischemia is there. Subendocardial ischemia. As I discussed, transmural infarction they present as ST elevated MI, but subendocardial ischemia they present as diffuse ST depressions. There is NSTEMI, diffuse ST depressions. Okay. So this ST, for example, in the ventricle, left ventricle wall is completely subendocardial ischemia is there. All the leads you are seeing some ST depression is there. To that reciprocally, you will have AVR ST elevation. You will have AVR ST elevation. Okay. Reciprocal to the ST depression of all these leads, inferior lateral leads, AVR will show ST elevation. That is one entity. Right, clear? And second thing is when can you get AVR ST elevation? For example, any small basal part of the septum, undergo infarct. Okay, then also you will have AVR ST elevation. And this basal part of septum is supplied mainly by the proximal left anterior descending artery. Okay, so in ECG you are seeing AVR ST elevation means there are only two indications. The one thing is either left ventricle is completely having subendocardial ischemia. Because of ischemia, ECG is producing ST depressions. So that reciprocally AVR is having ST elevation. Okay. Second thing is either some basal part of the septum is getting infarcted, because the basal septum also has elevation in the AVR ST elevation. Okay. These are the only two indications where you can see AVR ST elevation. Now let us come back to this slide. So AVR ST elevation can be seen in diffuse subendocardial ischemia with ST depression in lateral and all the leads. Okay, and also proximal LAD occlusion. Okay. So now how will you differentiate this thing? This is not STEMI equivalent. This is not STEMI equivalent. You no need to treat this thing. But this is STEMI equivalent. You have to treat because it's proximal LAD occlusion. You have to treat like a STEMI only. Okay. So how will you see this thing? Apart from the AVR, because septum is there, you can have V1 also ST elevation is there. Then you can label it as proximal LAD occlusion. You have to treat as STEMI equivalent. This point is clear? Okay.
Yes, sir.
So again, let me repeat this thing. AVR ST elevation, you have to treat like a STEMI equivalent. But you have to see whenever there is subendocardial ischemia, there is whole globally ST depressions are there. So that reciprocally you will see AVR ST elevation. So that is also one cause for AVR ST elevation. And second cause is basal part of the septum is involved. If it is infarcted, then also show AVR ST elevation. In this condition, apart from AVR, V1 will have ST elevation. Here there is no V1 ST elevation. Okay. If AVR and V1 ST elevation is there, you think of proximal LAD occlusion, you treat like a STEMI equivalent. If there is no V1 ST elevation, only global ST depressions are there, you just treat it like a diffuse subendocardial ischemia because of some hypoxia or hypotension, anything it is. Or post cardiac arrest, usually you will see this thing. Right? If this thing is clear, I can go for the ECGs. Right.
Yes, sir.
So let us see this ECG first. 1 minute, let me zoom. Yeah, see this thing? What is there in the ECG?
There is
See
diffuse ST depressions.
You can see the AVR ST elevation is there.
Yes, sir. And
You see, yeah, lead 1 ST depression, lead 2 ST depression. Okay, then V1 also ST depression, V2 ST depression, V3 ST depression, V5, every global ST depression is there. Then you go and see V1. V1 there is no ST elevation. This is RSR pattern, there is no ST elevation. Okay. Then I can label it as subendocardial ischemia. Usually happens in case of post cardiac arrest. Anytime patient undergo cardiac arrest, you need CPR. So he has already hypoxia is there, subendocardial ischemia is there. All the leads will be depression. Then after ST depression, because of reciprocally, we are showing ST elevation. It's not STEMI equivalent. This is not STEMI equivalent. Don't treat like a STEMI. Okay. If you observe also anytime after doing severe patient revived, his rhythm will be like this. AVR ST elevation, AVR ST elevation, thrombolysis. It's not STEMI equivalent. It's just only subendocardial ischemia because of hypoxia. Okay. Right. Now let us come to this ECG. Right. So now see this ECG.
AVR and V1 both have ST elevation.
Yes, simple thing. You have AVR ST elevation is there. Okay, let me change my pen. Okay. So AVR ST elevation is there. Okay, done. You have to identify the STEMI equivalent or only just ischemia. One is ST depression, 2 ST depression. Right, global ischemia is there. Okay, but if you see V1, ST elevation is there. Okay, it's a proximal LAD occlusion. This is proximal LAD occlusion. You have to treat like STEMI, otherwise patient will die. Simple. This point is clear.
Sir, ST depression is there is in 2 and
Yeah, so many things. V5, V6 also.
What does it suggest?
It's all reciprocal changes only. See the left. This is your AVR.
Got it.
Reciprocal changes only. Okay, na? Right. So
Sir, here V2, V3 don't have ST depressions, no, sir?
usually you will see ST depressions and lateral inferior leads. Usually, if subclip is there, complete you will see in all the leads.
Okay, sir. So this is not global ST
This is not
depressions.
global.
It is,
Yeah.
Okay, sir.
So what I want to mention one more important point here. 1 minute. And here I discuss this thing. Yeah. Here an important point to discuss. ST elevation has localizing value. What does it mean? If ST elevation anterior MI, if there is 2-3 AVF inferior MI, it has localizing value. But ST depression don't have localizing value. There is no localizing value. Okay. If you say like 1-2-3 AVF ST depression is there, I cannot say like non-STEMI inferior wall. Okay. There is no localizing value for it. That is important point. Okay.
Yes.
Just ST depression indicates subendocardial ischemia. That's it. Simple thing. Okay, that's will treat like STEMI only. But along with this, if AVR ST elevation is there, then you have to think of either diffuse subendocardial ischemia or it's maybe because of STEMI equivalent. That is clear? Okay. Then we go for the other things. Right. Okay. Just this is a extra amount of my curiosity I kept. If you can identify, it's a good thing. Just see what is this thing. Any changes are there? Difficult. Let me explain what the problem issues. See, here it is. ST depression in 1 identified. ST depression in 2 identified. ST depression in AVL. ST depression again, small AVF also. Okay, if you see again, V6 ST depression, V5 ST depression, V4 ST depression. So everywhere ST depression is there. Okay, then ST depression is there. You just want to know AVR. AVR is ST elevation is there. Okay. Again, V1 also ST elevation is there. Okay. But the only thing I have to mention here is this lead 3. In lead
Yes,
3.
sir. Concave ST elevation lead 3.
What? In lead 3 there is ST elevation is there.
Yes, sir.
Yeah. So usually if it is because of LAD occlusion or it's because of diffuse subendocardial ischemia, all the leads will show ST depression or they won't show anything. But they will not show any ST elevation. Okay. Here ST elevation is there in lead 3. This is called as Aslanger phenomenon. So what does it indicate? So usually patient has multiple vessel disease now with acute inferior wall MI. Okay. So it's a multiple vessel disease. That's why he's having subendocardial ischemia producing AVR ST elevation also. But suddenly acute MI inferior wall completely block is there. So that's why lead 3 is not showing any ST depression. It's instead showing ST elevation. That is called as Aslanger phenomenon.
Sorry,
Okay.
sir, can you repeat the Aslanger phenomena?
Aslanger, what is going to happen is patient is having a multiple vessel disease. Like all the vessels, some atherosclerotic block is there. Because of that, patient is having subendocardial ischemia. Because of there is some ST depression all the leads, and also there is AVR ST elevation. Okay, but now suddenly patient now presented as acute inferior wall MI. So because inferior wall MI is there in lead 3, instead of ST depression, you are having ST elevation.
Okay.
Right? This is called Aslanger phenomenon. If you can remember, you can remember, but nothing much. This is the NEET SS questions, 9 SS questions they will ask you. Just I want to mention this thing. I just mentioned, right? But my important suggestion is like when ECG is showing ST depressions, so please see AVR. If AVR ST elevation is there, then it can be either diffuse ischemia or it can be LAD occlusion. In diffuse ischemia, V1 is normal. In LAD, V1 is also ST elevation is there. Right? In such condition, again you see for the lead 3. If lead 3 any ST elevation is there, you can go for the Aslanger phenomenon. It is simple. Right?
Sir, the lead 3 is positive because of the acute inferior wall MI.
Yeah. Patient is having multiple vessel disease. Now he has acute inferior wall MI, acute RC occlusion is there. That's why he presented as lead 3 ST elevation. That is called Aslanger phenomenon.
Sir, Aslanger phenomena, isn't it proximal LAD obstruction?
No, he has a multiple vessel disease. Now inferior wall RC occlusion is there.
RCA.
Yeah. Okay. Just remember this thing, nothing much. The Aslanger phenomenon you have to see through the lead 3. That is the important point. That was the bit asked in INSS. Okay. I think we are completing ECG. So let us see. Okay. So this is ST STEMI equivalent. When I discussed post-wall MI, other I discussed this AVR ST elevation. Now let us see this thing. What is this thing? Anyone can identify? This also discussed in theory class. Very important ECG.
Biphasic T valence.
Excellent. See V1, it's a biphasic T wave swing. Okay, this again biphasic T wave. Okay, this again biphasic T wave. Okay, what is this thing? Okay, no problem, we don't know. See the second ECG, we can discuss again with that.
Symmetrical T wave inversion valence type.
What is this thing?
Symmetrical T wave inversion.
Deep T inversions, V1, V2, V3, everywhere T inversions are there. What is this thing now? What is this phenomenon? This is the different asking question.
Juvenile T wave.
Again, this is a discussion of theory class. I think in Mentora, first class is my demo classes regarding this.
Valence phenomenon.
Excellent. This is a valence phenomenon. It's going to be a question. It's a valence phenomenon. Okay. So we discuss about this valence phenomenon. So what is Wellens phenomenon indicates? It indicates again your proximal LAD occlusion. Okay, right. What is it going to happen? We'll see. Right. So what is going to happen here in Wellens phenomenon? Right, Wellens phenomenon. This is LAD, this proximal LAD. Suddenly this got occluded. Okay, the patient immediately will have chest pain, full of chest pain, diaphoresis. Like same patient typically presents to you like a chest pain, diaphoresis. Okay, but immediately, so chest pain, diaphoresis is there. Okay, so immediately it will undergo thrombolysis. Some patients will undergo spontaneous thrombolysis. So then your chest pain will be resolved. So by the time he comes to hospital, there is no chest pain. Okay, if you take ECG here, okay, after post they will have biphasic T waves. So this biphasic T waves indicates what is called as post thrombolysis. Okay, even when you give tenecteplase or something thrombolysis also, you will see this biphasic T waves. Okay, now what will happen? You thought, okay, nothing is there, no ST elevation is there. If you discharge this patient, it's very problem. Okay, if you admit the patient, then you do monitoring and all. Now again patient will develop chest pain. Suddenly patient will have again clot will form. Again patient will have chest pain. Okay. Now you do ECG. What will happen? In the ECG, first thing is hyperacute T waves and STEMI. But already T waves are here biphasic, so they will become normal. So P, QRS, because biphasic has to become hyperacute means they become normal. That is called as pseudo normalization. You think ECG is normal? Nothing is there. Okay. Again, if you repeat the ECG, then patient will develop some deep symmetrical T waves and all. That is LAD occlusion. You understand this thing? Okay. Proximal LAD occlusion is there. It has a more propensity to undergo spontaneous thrombolysis. So whenever the patient is having chest pain, diaphoresis, he will have ST elevation or something. But by the time he comes to ECG, he comes to hospital, this thing is complete, thrombolysis is done. So spontaneously, so he will develop some biphasic T waves. That is called as Wellens T waves. Okay, so if you leave like this, then again patient will develop chest pain. Then after patient developing chest pain, if you take the ECG, this instead of hyperacute waves, this biphasic T waves will become normal. That is called as pseudo normalization. You think the patient is normal, but later again he will develop into some ST changes are there. Okay, usually when patient is having no chest pain, then only you will see this biphasic T waves. When patient is having chest pain, ECG is normal. That is called pseudo normalization. That is the thing. Okay, so this Wellens pattern can be of two types, type A or type B. In type A, you will see what is called as biphasic T waves. In type B, you will have a deep inversions. That's it. For you, our level, it's enough for that. You just see this ECG. This ECG is showing, as I discussed, this is a biphasic T waves. That is your Wellens type A. This is your type A. Okay, and this is your deep inversion. That is your type B. That's it. So take home message is, if patient is having chest pain or something, he came to ECG, he came to casualty, you took the ECG, you saw biphasic T waves, please admit the patient. It's a proximal LAD occlusion. Go for angiography. Okay, even chest pain resolves also. Patient chest pain resolves because it's undergoes spontaneous thrombolysis. Okay, or deep inverted T waves are there, again you admit the patient, you have to go for angiography. That's a Wellens phenomenon. It was first described as Wellens, it's called Wellens phenomenon. So clear? You consider it as a STEMI unit, STEMI equivalent again.
Happens
But
only
the
in
thrombolysis is not advised in Wellens.
Thrombolysis is? Yeah, that
Not
time again
advised.
patient is having active chest pain is there, yes, you have to advise the patient. If patient is no chest pain is there, already spontaneous thrombolysis, we will again thrombolysis. Okay? Any doubts?
So it happens only in proximal LAD, no?
Yeah, usually because proximal lead is very, very important in our heart vessels. So our body has defense when there is spontaneous thrombolysis.
Okay. That's why it undergoes spontaneous thrombolysis. Okay.
So for your level, what you have to understand is Wellens phenomenon is a STEMI equivalent. It indicates proximal LAD occlusion. It can present in two forms, either biphasic or deep inverted T waves. Any patient complaint of chest pain, or if you see the biphasic T waves, ask the patient what is the chest pain history. Maybe he is not, but before he had a chest pain. It's a Wellens phenomenon. Send for angiography. That's it. Okay.
Okay, sir.
and the last and the final STEMI equivalent is LBBB, right? I discussed already. If new patient suddenly he is in hospital only, he is in the hospital, okay, normal ECG he has. Now patient develops some chest pain, okay, patient has LBBB. It's a new onset LBBB, you will take it as a STEMI, right? But already patient had LBBB, now he has chest pain. Then how to diagnose MI? MI, you will use a criteria called as Barbosa criteria. This is again excellent, important question, ask a question, and also your Viva was question in the ECC they will ask. How will you identify ST-related MI in a patient who is already having LBBB? That is Barbosa criteria. Right? According to what is the criteria you are seeing, for example, patient is having LBBB, if ST elevation is there, whether it is STEMI or not, or whether it is because of the LBBB ST elevation is there, you are seeing. So how can you identify? There are 3 points are there. One is concordant ST elevation. What is concordant ST elevation? Positive QRS is there, then you have ST elevation also. Positive, both are positive, it's concordant. Concordant ST elevation of only 1 mm. Okay, and this is concordant ST depression. What is concordant ST depression? ST QRS is negative and ST also depression. It's called concordant. Concordant ST depression of more than 1 mm. And discordant ST, discordant means QRS is negative but ST elevation is positive. That's called discordant. So discordant of more than or equal to 5 mm. Right? So that's what they discussed here. Just write down this thing. Sorry. Right. So concordant ST elevation of more than 1 mm, concordant ST depression of more than 1 mm, or excessively discordant ST elevation more than 5 mm. So if it is there, it's a score of 5 points, it's score of 3 points, it's score of 2 points. If more than or equal to 3 points are there, you can diagnose it as STEMI. Mostly it's a STEMI only. Okay, understood this concept? This is the last STEMI equivalent. So what I'm saying is, again I'm repeating, if any patient is having LBBB, if the patient is having ST elevation, we cannot say whether it is due to LBBB or whether it's because of MI. So further thing, they developed a criteria called as Barbosa criteria. So what is the criteria they're saying is concordant ST elevation. That means in a leads which is having positive QRS, if ST elevation is more than 1 mm, and concordant ST depression. That means in leads which is having negative QRS, there's ST depression of 1 mm, and discordant ST. That means in which is a negative QRS, ST elevation of more than 5 mm. Then you can take it as a discordant ST elevation more than 5 mm. They give 5 points, 3 points, and 2 points. More than equal to 3 score is there, they will take it as STEMI. Any doubts?
No, sir.
Yeah, clear? So just for you, if you can remember or not, just only remember the name at least. In a patient of LBBB, to diagnose STEMI, you are using a Barbosa criteria. Okay? Then some examiners are very keen and interested to ask about Barbosa criteria. Right. That's it. This completes our STEMIs. Any doubts?
No, sir.
So just I will summarize this thing, then you know it's better. See, any MIs and all, first thing you have to do is what type of MI, what is the stage of MI, like acute, subacute, chronic. Okay, hyperacute, acute, subacute, chronic. Second thing is, if ST elevations are there, you can label it as a ST elevated MI, and ST elevated MI has a localizing value. Just localized anterior or inferior or lateral. Okay. Then if ST depression is there, it is not localizing value. Okay, it is mainly NSTEMI. Okay, if ST depression is NSTEMI. Now the thing is, if ST depression is there with AVR ST elevation is there, okay, with B1 also ST elevation is there, it is STEMI equivalent. Very important point. It indicates your proximally occlusionally or left main coronary occlusionally. Clear? Right. Apart from this, other things, in the case of inferior MI, see for the posterior leads also, like V1, V2, V3 you see. If any V1 ST depression is there, V1 tall R waves are there, and upright T waves are there, check for the V7 posterior leads also. Okay, that is again, that's called as posterior MI, that's again your STEMI equivalent. And second thing is very important, Wellens phenomenon. If you see any biphasic T waves or if you see any T inversions are there, just ask the patient retrograde history, what is the chest pain history, Maybe patient is having previous chest pain, so please don't discharge. Proceed for the angiogram because it's a lead occlusion. And last, if patient is having LVBV, please apply Garbosa criteria to diagnose MI. Okay, this is the basic summary. Clear? All the points are clear? No issues?
Yes, sir.
Yeah. So don't think it's a very complicated thing. It's an easy thing. It's must known thing. For a physician, MI and tachyarrhythmias are very important things. Sleep you have to identify. You should not miss. It's a negligence. If you miss this thing, it's negligence. You cannot miss STEMI. You cannot miss NSTEMI. You cannot miss STEMI equivalents. All the STEMI equivalents you should know. AVR rest elevation, Wellens phenomenon, LBBB, post-pral MI, everything you should know. Right? Then comes your management. Very simple. We're coming to the end. Don't worry. Okay. If you come to the STEMI, how will you manage? Whatever the STEMI patient, very important points are immediately patient comes to casualty and door to ECG time. Take the ECG and diagnose within 10 minutes. These 3 points are very important. Okay. Then, if you are in a very high-tech hospital, if you have a cardiology department in situ, if you can do angiography, you have to proceed for angiography. Proceed for angiography. That's what they mention as door to balloon time of less than 120 minutes or 90 to 120 minutes usually. Okay, like if you're in hospital, you can call the cardiologist, you can do angiography within 90 minutes, just proceed for angiography, nothing else is required, right? Or if you're in a remote place, you cannot go for the angiography immediately. If your door to balloon time is more than 120 minutes, yes, you cannot do this thing, then you have to go for the thrombolysis. At least thrombolysis is the better option, you have to go for thrombolysis. In such condition, your door to needle time, that is thrombolysis, 30 minutes, very important thing. Right? See, I am in the casualty. I got a patient. He is complaining of chest pain. Immediately, I have to take the ECG and diagnose MI within 10 minutes. And after the diagnosing and all, I have to see, okay, this is STEMI only. I have a cardiologist available. So within 2 hours only, I can call the cardiologist and do angiography. I won't give thrombolysis. I call the cardiologist. I'll ask them to do angiography. That should be done within 90 minutes. Okay? Or if there is no cardiologist, I have to send the patient to cardiology hospital that is very far from my city. It's a remote place. So I cannot leave the patient like that. I have to thrombolyze. In such scenario, within 30 minutes, you have to do thrombolysis. Okay? Simple thing. And last and final point, usually if patient comes even after 2 hours also, always gold standard is PCI only, angiography only. But if PCI option is not there only, you have to go for thrombolysis. You can do thrombolysis until 6 hours, right? But if chest pain still presents, you can go until 12 hours. Right? This again a key point. They'll ask you what they'll ask you. Here represents the remote area. They have to ECG posterior MI. You are in remote area. To refer to cardiology hospital, it takes 3 hours. What is the next step? Yes, you have to thrombolyze the patient. Or you are in some city and cardiologist is available. What will you do? You will do angiography. Clear? Right.
Yes, sir.
Simple. Don't confuse. Please, you are going to practice outside now. There are so many lives in your hands. Okay? Be wise and take smart decision. And NSTEMI, you are not thrombolyzing. No need of thrombolysis. No need. Okay, because it is only subendocardial. It is not intramural, not transmural. There is no complete occlusion of vessel. There is no point of thrombolysis. Okay, simple. And thrombolysis, what are you using again? Streptokinase, tenecteplase, RTplase, retiplase. You're using, but mostly you're using only streptokinase and tenecteplase. In low resource settings, streptokinase 1.5 lakh units you are giving. In high resource settings, your tenecteplase, it's exactly 0.53 mg per kg, half of the body weight. Right? That's it. Out of all, which is more specific, more best, tenecteplase is more fibrin specific. It's very highly effective. Okay? So streptokinase usually hypotension side effect, anaphylactic reactions are side effect. So more bleed is a chance. Usually you don't prefer, but streptokinase cost is only 5,000. Tenecteplase cost is 50,000. 36 to 40 to 50,000. Right? Right. So this is done. The next what I will ask in my, I already mentioned the one point. 4 MI. Okay, see, definitely if it is a right ventricular MI, you can give fluids. Okay, but until see for the JVP. If JVP is raised, you cannot give fluids. That's clear. Okay, so right ventricle MI is there, so right ventricle is not contracting, it is not pumping out. You have to make it contract, you have to increase the preload, so that preload will go to right ventricle will contract. But whatever you are giving preload, it is not contracting, it is coming up as JVP, this is point again, it's only fluids. So are fluids recommended in MI? Yes, in right ventricular MI, but still only until JVP is normal, right? And second thing is, nitrates are very much contraindicated. Very important. Patient is having chest pain. If patient you see the ECG of any right ventricular MI is there, you should not give nitrates because it worsens, because preload is decreased, right? That's it. Left ventricular MI, never fluids, because if you give fluids, it will go into hypertension. Never. Nitrates are recommended here. Rest all things are same, only morphine, painkillers you can give opioid, and other things are dual antiplatelet therapy and statin you give, anticoagulation you give. Please study anticoagulation, go for the exam, right? And the last thing is, they'll ask you what are the complications of the MI. So if they ask you, just write a simple thing, whether it's a mechanical complications or electrical complications. This all we discussed in the theory class, so I'm not going deep. Mechanical complications, usually you will see in the case of left ventricle MI, either BSD or either MR, metal regurgitation, or maybe because of ventricular aneurysm also. Okay, electrical complications mainly VT, VF, and your premature complexes. And this VT, VF is more common within 1 hour, so that's some more common cause of sudden cardiac arrest is VT, VF. Right? So this is what you have to discuss in the complications. Don't say what are the complications with hypotension, what are the complications with some bradycardia, or nothing. Those are not clear. Be specific. Mechanical, electrical, mechanical, VSD, MR, and your ventricular aneurysm, and electrical is your VT, VF. Right? And mostly, commonly, they say like anterior MI usually associated with the hypotension, inferior MI usually associated with the bradycardia, because AV node is supplied by the right coronary artery. Right here. That's it. The last, there's no time, but people please study about these drugs and go. Very important. Adenosine, digoxin, amiodarone, metoprolol, diltiazem, heparin, anticoagulants. Okay, please don't miss. What are the drugs? At least mechanism. Adenosine is only just, what is the mechanism? Adenosine is a
AV blocker.
why AV node blocker? In AV node there is an adenosine receptor. That adenosine receptor is a GI inhibitory. That is why it's AV node blocker. Okay, that's very important. Adenosine acts on adenosine receptor, which is AV node. That adenosine receptor is a GI type of, that's why it's adenosine blocking. And digoxin, just little bit with digoxin we'll discuss. So what is the mechanism of digoxin?
Sodium, potassium.
Excellent. Sodium, potassium, ATPase pump inhibitor. Okay, so what is going to happen? Let us see here. This is your cell. Okay, this is your sodium, potassium, ATPase. It will help to cause 3 sodium outside and 2 potassium inside. Okay, now what is going to happen? This digoxin is blocking this pump. Okay. It's blocking this pump. If it is blocking this pump, what is going to happen? Sodium is not going outside, sodium will be accumulated. If sodium is going to accumulate, what will happen? Cell has to pump the sodium out. It will activate one more pump called as sodium calcium. Sodium will be pumped out and calcium will be taken in. Okay, so because of that, calcium will be increased in numbers. Calcium is increased in numbers. So because calcium is there, it causes inotropic action. So because calcium is there, is inotropic action. Okay, that is why you are giving digoxin and heart failures. Okay, so if you don't remember all these things, just remember sodium is sodium potassium channel ATPase pump inhibitor. Because sodium potassium pump is inhibited, calcium is accumulated in the cell, leading to what is called as inotropic action. Okay, and also digoxin, apart from this, it also has a AV nodal blocking action because it's a parasympathomimetic at high doses. That's why it also uses the AV nodal blocker. Okay, I'm not going much into the drugs. Please study about the digoxin. Very important. What is the side effect of digoxin?
Hyperkalemia.
So digoxin, it's blocking this channel. So potassium is not going into the cell. Potassium is accumulating outside, leading to what is called hyperkalemia. Very, very important thing. Okay. Right. And emetron, it's again potassium channel opener. You have to study about the half-life is 53 days. And what are the side effects are there? Side effects are very important. Pulmonary fibrosis, liver failure. Again, it's alpha-1 block, hypotension. All these things you have to study. Metoprolol, just you have to remember the dose only. Diltiazem I discussed, 0.2 mg per kg. Heparin, both you have to remember unfractionated heparin and low molecular heparin. See, I cannot discuss all these things. These are all just nothing to explain to you. I can discuss about ECG and all these things because they are the things which are keeping in exam. You have to discuss. This is theory part you can study. Definitely study about unfractionated and low heparin. You have to discuss about it also. Heparin-induced thrombocytopenia. We discussed in theory class. Just go through the thing. Okay. And anticoagulants. Please study about the classification. What are the direct anticoagulants? Indirect anticoagulants. Okay. What are factor 10 inhibitors? What are thrombin inhibitors? What is dabigatran, hexaban, rivaroxaban, and antidotes also very important. Dabigatran antidote. Anyone can say?
Idarizumab.
Nidarizumab. What is the antidote of factor 10 inhibitor?
Antagonist alpha.
Okay, these are the common, very interesting. They want to ask these questions. Antagonist alpha. They won't give, but still they will ask these questions. Okay. And the last and the common side is LBB, RBB. I think you can identify this thing. So what I will say is, just see in ECG, there is wide complex is there. Okay, go for the V1. Okay, if V1 is positive, it is RBBP. If V1 is negative, it is LBBP. That's it. Simple. You should be very, very simple. Okay, this is what they say, like William Marrow. I think you remember William Marrow. William Marrow. They used to give a mnemonic in a childhood. William Marrow. This is V1. This is V6. Okay, in LBBP, this is LBBP. V1 have negative, V6 has positive. Similarly, in RBBP, V1 has positive M, V6 has double M. In a simple way I told, you just see wide complex, then you see the V1 lead. If it is positive, RBBP, if it is negative, LBBP. That's it. Okay. That's it. So this completes our ECG. Any doubts you can ask? Okay.
Okay, sir.
Yes. Please don't leave the ECG. Definitely MI is one question they will ask. And again, what is this thing? Tachyarrhythmias. This is also one more question they will ask. Bradyarrhythmias, there is nothing to mention about bradyarrhythmias. So bradyarrhythmias usually first degree, second degree, third degree heart blocks are there. First degree is again your prolonged PR interval. Second degree mobility type 1, type 2, and third degree complete AV block. Complete AV block again they will ask you question. Just AV dissociation you have to show. That we discuss in theory class only, right? So this is our ECG. All the ECGs we discussed here. This narrow complex. This again wide complex. This DDs of wide complex. This flowchart is very important. Then DD of wide complex is very, very important. Pacemaker, period tachycardia, you have to identify this thing. This is our ECG we kept here. Then we discussed VT. This slide is extremely important. Even if you don't remember everything, just identify those 5 lines. Extreme axis deviation, capture beat, fusion beats, positive, negative components, and also you have left right tear sign. Okay. Then you have to identify monomorphic and polymorphic VT. So polymorphic VT, different amplitudes are there. Drug of choice is magnesium sulfate, right? Okay. Management and all we discussed. Unstable, always cardioversion. Supraventricular tachycardia, you have to give immunotic blockers. Immunotic blockers only 4 drugs: Ritenosin, beta blocker, calcium blockers, and digoxin. Right? AF first is rate control, then go for the anticoagulation. Then comes a VT. In the VTs again, if unstable, same shock only. If it's a stable, you are going to go for monomorphic, you go emetron, polymorphic Maxwell. If digoxin induced or MI induced, you can go for lidocaine. Right? Myocardial infarction we discussed all. This is the most summary I gave you here. Please don't miss this. All these things I discussed are all very, very important critically also. You should be in a position of not missing these ECGs at all. Okay? Identify STEMI or NSTEMI. If it's an NSTEMI, just go for the AVR. If AVR ST elevation is there, definitely it is some diffuse subacute ischemia or LAD occlusion. Then go for V1. V1 is having ST elevation. Then go for lead 3 also. If lead 3 ST elevation, as Langer phenomenon, you have to know about the thing. Right? And Wellens, this STEMI equivalents are very important. Post-ball MI is important. STEMI equivalent, AVR STEMI is important. Then Wellens is important. And then LBB Garbosa criteria is very important, right? I think we covered completely. Any doubts, you can message me, you can ask. Any doubts, no one, you can ask. If no doubts, you can stop the class. We'll continue the other class. So one small thing I want to say. So this is what we started with DNB practical crash course. So this is the way we are dealing. So ECGs and all we discussed. I am going to cover your neurology topics. I am going to cover your gastroenterology topics. And second thing is I will deal EPG also, and CT, MRI, and some OSCE also. Locomotor system also I am going to cover. And one more madam, Anshu madam, she is going to cover your respiratory and CVS, all these things. So this is our approach. So we'll give you completely clinical oriented things, not only for the exam, for your practical purpose, right? So any doubts, even if you don't study for practical, start from now. Study with us, it will be very easy for you. Just happily you can go very confident into the exam, right? Any doubts you can ask, otherwise we'll meet in another class.
Thank you.